little bit. You know, there's some MSK stuff as well.
Yeah. Has anybody been? Thanks, Stuart. Has anybody been redeployed into this kind of managing COVID restoration?
There is a team. I think there's a long COVID team, but I don't know much about it, to be honest. So
yeah.
But
I have to say
they sat just behind me.
okay, well that's them, and they're wonderful. That's what I would say.
Absolutely.
Is that Denise? Morning, Denise.
Good morning, Kay.
No, actually, we do have long COVID team as well now. I've managed to refer a few people, and that seems to be brilliant because it's really truly interdisciplinary. Although they still have to adopt the respiratory team into the the family, as it were. But that seems to be working really. Physios are playing very, very important role in it. That's brilliant. You know, I thought this is just aspirational, but turns out actually I can refer. And only yesterday I had the first letter back, so actually it's working. Brilliant. Okay.
I'm going to hover my Mark. Morning, Mark.
39.
Good morning, Cardiff calling.
Morning, Cardiff.
How are you all?
This morning.
Looking forward to this morning. I've had 2 cups of tea already, so it's going well.
Oh, lovely. And I hope we get some sunshine down there today.
50 cups of coffee. Mind you, before we start, I might as well just go downstairs, have another one, just in case.
Where are you based, Mark? And what's your area of interest?
Say that again. So where am I based? And
yeah, what's your area of interest?
So I am based in Cardiff and Vale Health Board, and I am a member of the FCP team and the CMATS team. So seeing how we can use STarT back in our daily jobs to make our lives easier. Fingers crossed.
Great.
I think I'm all about that at the moment. How can we make our job easier for ourselves?
Yeah.
Welcome to the club then.
Yeah. And Adrian, have you had a few queries about people using STarT back as part of the sort of telephone triage?
Yes, and both triage telephone and trying to implement it within their own online systems, as it were. So the online systems, probably the easiest way, actually, people just going on our website, so just telling them, look, this is where the calculator sits, and theoretically you just open a browser and you go through the calculator. But there are a few questions, yes, about some technical details because they want to implement it into the whatever software they're using. Telephone, I think I have one query, but most of people are using it as a mix, kind of more multimedia, sort of video, telephone, and face-to-face as well. But yeah, it's basically becoming like a plugin, and people are trying to plug it in whatever it is that they're using, the tools. Which is, I think, really, this is what this is all about, isn't it? Just to use it as one of the tools.
Yeah.
Hello, everyone. A lot of the GP practices in Cardiff are using like the e-consult triage now, and depending on what the patient puts in, the STarT back tool does trigger, if they put in back pain specifically. There are limitations to it, but yeah, it's starting to come into that initial triage, when they first hit the GP practices as well. That's great.
Dallas, can I ask you, how's FCP going in and around Cardiff? Have you got a number?
Yeah, in Cardiff, we're out in all the sort of delivering like a cluster-based model. So we're in all the GP practices, but within sort of cluster hubs. But we've been virtual and out of GP practices during COVID. But starting last week now, we've just started going back into GP practices, but still doing virtual. So yeah, the next step will be then when we can opening up a bit more face-to-face again. Yeah.
Have you had any indication from the Welsh Health Board when that might be?
No. There's a bit of work going on in the background to kind of get all the risk assessment stuff sorted for cluster working, but I think that's all being sorted now in anticipation for it happening at some point, but there's no agreement yet.
Yeah. Adrian, have you heard anything from sort of GP?
From FCPs? So the PCNs at the moment are looking into basically, hiring people. But this is still not just FCP, so there's going to be, the care navigators, extra physiotechnicians, social prescribers, FCPs. Guess what I was pushing when we asked who do we want in our PCN?
More physios.
Absolutely. Well, some physios, because as a PCN, we really don't have a lot. I mean, those that we have are brilliant, but there's just not enough. It's not enough. I think one of the problems with physiotherapy is it's almost because of the way system works. Patients are immediately managing their own expectations, lowering it down, not because of the quality of what they have physio, but the waiting time. So when I mention physio, I can see the faces droop because they see, oh, I'll have a letter in 2 months' time. I can immediately see what's going on with the head. And the problem is I cannot really tell them, no, you're wrong, mate. It's going to be a week time or a fortnight and you get seen in a meaningful way. So that's the problem. So yes, absolutely, more physios.
Definitely. I think we've also got some members of our Malaysian friends joining us this morning as well. So I think we'll do some introductions in a little while. But welcome to Sujay Yu. I think we've got some of our Malaysian colleagues coming on.
Yeah, we do.
Yeah, lovely. So is there anybody from the Malaysian team who wants to say hello?
Hi, Zara here.
Hello, Zara, nice to see you. Hi.
Hi, how are you?
Malaysia meet Cardiff, Cardiff meet Malaysia.
Thank you very much for having us and sharing about this workshop. We're very delighted to participate.
So Zara, do you want to tell everybody a little bit about what you're doing in Malaysia around STarT Back? Because I'm sure everybody will be interested to hear.
Yeah, so this is part of our research project to implement the STarT Back tool in the primary care setting in our teaching hospital. So I'm basically from the Department of Primary Care. So we are hoping to start the trial soon by next month. So this is a very good timing for us, the physiotherapists, occupational therapists, and me, representative of a GP, to have an idea of what how you implement it over there, so that we can adapt it here. Yeah.
Super. You're very, very welcome, Zara. And what time of day is it for you?
It's 10 to 5 in the evening.
I want to say, Cardiff team, honestly, because clearly Malaysia is very committed. By the time we finish, it's going to be what, 10 o'clock almost?
Yeah.
In the evening. So I don't want to hear things like, oh, I'm tired. Sorry, we can't say that.
Well, you're all very, very welcome. And just to reassure everybody, so Zara and her team are kind of like you, just here for the kind of the learning. You're not part of the research. So Zara and her team are just here to kind of hear some of the techniques that and share the expertise of Katie and Steve and Adrian as we go through the session. So you can see that we're trying to share the love across the world with STarT Back. So it's good to see you. Anybody got any comments, thoughts, or questions? I'm just going to have my. I'm going to come back.
I have one as usual. I just wanted to say hi to Delith because we emailed each other and spoke over the phone a few times. The first time we actually see face to face.
Hi, Adrian. Nice to meet you. Hello.
Okay, so who haven't we said hello to?
And I have to say, Kay, you were my mentor 20 years ago when I was in Keele University. You won't remember me, but I remember you.
Possibly 20 years ago. Absolutely.
It was about 1996. Or about 1998. Sorry.
Oh, kept you back again, Delith. Brilliant. Oh, you look fantastic. So clearly enjoying life. Yeah, great. Oh, it's lovely to see you. Lovely to see you. You're supposed to say then, Kay, you don't look a day older.
Sorry, I put my mute on then. Sorry, I was a bit slow. So
I think it's not 20 years. It's probably 12 maybe, or 2 years, but not 20. That's not possible.
No, it was 20 years ago. I was trying to remember the name of the practice you were at. It started with L, but I can't. It's gone from my mind now.
And maybe Lockton Cottage, maybe.
Yeah, that rings a bell. Yeah, I think it was probably there.
Oh, well, it's good to see you again.
And you. And you don't look a day over.
Thank you. Yeah. Perfect timing. Perfect timing. Fantastic. So who else have we got with us? Esther. We said hello to Esther, haven't we, I think?
Hello. Sorry, I just turned my camera on. Say hi. Hello.
Good to see you. How are you?
Yes, I'm fine, thank you. Working from home today, so it's quite a luxury. Yeah,
Lovely
no,
picture
looking forward to it.
you.
Sorry?
A lovely picture behind. There's a photograph behind you.
It's our favourite place in Gower. So in West Wales. So yeah, we love it there.
Yeah, I normally put this as my virtual background, my favorite place, but today I decided I'm going to be professional, and this is just my office.
So how are we doing on time?
We are 45 persons just admitted, so
everybody, fantastic. Is there anybody else who wants to say hello? And I guess what we could start to have a conversation is about what you want to get out of today. So maybe that's. I'm interfering now. I'm going to be quiet. I was only supposed to be here as a kind of observer. And
yeah. Okay. So let me just warn you. Kay will interfere. Okay, as I would normally. But that's normal. If she doesn't, ring 999, and we need to send somebody to her. That's not normal for Kay not to interfere. Oh, we got yet one more person. So shall we start? I'm just really mindful that the team on the other side of the planet will be finishing late in the evening. Shall we? Okay, let's go then. Well,
Samantha.
We got somebody more. There we go. Right. So good morning once again, and warm welcome. On this, well, at least here, cold, a bit miserable morning. That's one of those days that makes you think actually working from home is not such a bad thing. And this is just, stating obvious for people in the UK, and update on the weather conditions for the Malaysian team. First and foremost, I promised Laura actually was first to join us this morning, and that only goes to show that being a mum and multitasking is not a problem. Okay, she was first waiting in lobby, and I've admitted her as the first. I promised I'll tell her so. Please, round of applause. That's the prize, Laura, if you're still there.
I'm still here, yeah.
Okay, brilliant.
The kids have gone to school. The littlest one is still here, so I'll probably just keep myself on mute.
Brilliant. Okay, so anyway, good morning, everyone. Welcome to our new StartBack course. New hybrid form, new title, new delivering team, as you'll find out in a moment, and slightly different aim as well. By new, of course, I mean better. So let me just first introduce myself. We'll do the introduction later on, but just starting from me so that you know who's this guy who keeps talking. So my name is Adrian Hudik. I'm what we call a GP academic, which means that I share my time between the university and the position of a jobbing GP. So I'm a GP and physician by background, and I'm also NIHR clinical lecturer, and this is important, a member of Key Impact Accelerator Unit, and we'll talk about it in a second. I'm partner of Park Medical Centre, that's a practice in Leek, which is situated in Staffordshire Moorlands, just at the foothills of the lovely, beautiful Peak District. Not trying to compete with Cardiff, Wales, or with Malaysia, okay? But it's lovely bit of country that we have here as well. I think last not least, and so that you cannot say that you haven't been warned, I'm also a GP StartBack champion, okay? So I'm not going to be objective 100% about StartBack, because that's what I do and that's what I love. I've just mentioned that I'm a member of the IAU, Impact Accelerator Unit. I think it's probably worth, or maybe actually more useful, if I just say a few words about the IAU. not just to kind of blow our own trumpet, but probably will give you more of a context as how this all came about. So the Impact Accelerator Unit is a part of the Keele University. It is a multidisciplinary team, and that's led by Professor Krisha Jedis, who's also a physio by background. So within the team, we have researchers, we have clinicians, all sorts, so physios, GPs, nurses. We've got the communication and the patient participation experts. We've got healthcare managers, we've got knowledge mobilizers, we've got business liaison experts. So pretty much you name it, we've got it, okay? But when we think, there are some areas still outside of our expertise, or I don't know, we just know somebody who knows better than we do, we're not shy to ask a friend, and we ask for expert advice in that situation from the experts from outside of our team, and you'll be able to find out actually for yourselves today. So in truth, most of us wear 2, if not more, hats at the same time. And I think this is actually where our strength is coming from, because we are able to talk, different languages. And by that, I don't mean that my native language is Polish, but we can basically see different sides of this story, be clinical implementation from your personal and kind of a professional perspective as well. So what the IAU does as a unit is we translate the world-leading healthcare research results into real-life results. So we aim to have a positive and probably more importantly a sustained impact on healthcare, mental care, social care, public health, and generally wider health economy. So we're trying to achieve it by implementing, or at least supporting, these wonderful, innovations that both researchers and quite often through the businesses, also innovative businesses are coming from. They keep producing them. I mean, I think it's fair to say that, because of our main area expertise, we do concentrate more, but not exclusively on primary care. And this is exactly how the whole training is actually coming about. So, as you know, the STarT project, the STarT trial took place in 2008, so it's been a while, with then Impact Back as an implementation study following on a few years later. And the results were, very positive, very encouraging, impressive, really. But then we were kind of left, with the task of making sure, all this effective low back pain intervention is known and actually used, far and as wide as possible. So you can now see this is an example where, the positive evidence-based intervention as an output of Keele University research, and in that case, it was led by Dr. Jonathan Hill for STarT and Professor Nadine Foster for Impact Back, has been taken up by the IAU to ensure that its implementation takes place, and one of its forms, not the only, of course, is actually this STarT course. So that's why, it's our pleasure, to deliver this course to you guys over these 2 mornings, today and in a fortnight on the 8th of April, in 2 weeks' time. Right. Obviously, you're not going to be left at my mercy, so you should be grateful for that, I'll tell you, and on OK only. We also have, in no particular order, Katie Jackson, Laura Campbell, Stephen Henderson, and Nikki Evans. So that's the team that's going to talk to us today. And next week, we'll also be joined by Kay, not just an observer from the IAU, who's an honorary professor there, and Paul Shawcross from Connect Health. So in a moment, I will let them introduce themselves properly and we'll come back to the course. Yeah, I was thinking about, kind of a little round of introduction now, but I'm not sure whether that makes sense now because we pretty much went through, Kay's around, what can I say? So I'm just thinking maybe in that situation, I would ask Katie, Laura, Steve, and Nikki to introduce themselves first, and we'll come back to me in a moment, if that's okay. Katie, are you there?
Yes, I am. Hello, everyone.
Hello.
So I'm Katie Jackson. I am a physiotherapist working in the Impact Pain Service, which is a community rehabilitation service for people with chronic pain. Nice to see you all.
Brilliant. Who's next? Stephen? Stephen, you there? Okay, Laura?
Can you hear me?
Oh, yeah, okay.
Yeah.
Go ahead, please.
Hi, everyone. Sorry, I made the first mistake of switching to large gallery preview and recognizing how many people were actually on this call.
No,
That scared me a little bit. So I'm Steve Henderson. I'm also a specialist physiotherapist in the Impact Pain Service based at MPFT Trust. So nice to see you all.
Lovely. So we got Laura and Nikki.
So Nikki's just had to nip into another meeting.
Oh, yes. All right.
Yeah. So, but Nikki is our Impact Accelerator Unit Manager, and she'll be in and out for most of the morning. I'm a knowledge broker in the Impact Accelerator Unit, and also and field student in knowledge mobilisation. So I do a lot of work with our patient groups for implementation work, and a lot of communications and stakeholder engagement work.
Brilliant, lovely, thank you. So I can see that Kay, as usually, very insightfully suggested that, you know, guys, if you have any particular strong feelings about certain aspects, outcomes you would like to get from today's session, just put them into the chat, okay? It's all recorded, so nothing will be lost, and we can then look into it and hopefully kind of adjust the session as we go along. All right, so thank you very much. So coming back to the course, I'm going to check. So as you know, the title is Practical Solutions to Managing Patients with Low Back Pain Using Stratified Care Approach, STarT Back. So the title is a little bit long-winded, okay, a bit like those medieval books with the, you know, the spoiler at the title cover. But actually, you know, it needs to be informative because our plan is effectively to give you exactly what it says on the tin. So the new format, the online, serves two purposes, and I think we actually alluded to this slightly earlier, talking about the online delivery. Obviously, COVID, pandemic, other options are simply not feasible. But it's also our response to the feedback we've received over the years, both through the face-to-face course and through colleagues that were contacting us, basically asking for more accessible form of the course. So, you know, like everybody else within the research and in NHS, we were thinking about it for a while, we were mulling it over, and, eventually COVID came along and forced our hands. So here we are. Now, I hope you all have completed the online course. I know it might have felt a little bit dry, a bit theoretical, but it would certainly equip you with some kind of required knowledge to be able to, benefit from this, the more practical and interactive part. I appreciate there were some technical problems and especially with login. For some reason, every update we had similar situation, and the updates happens without our control. So that's just unfortunately the technical problems. But I'm sure everything will be fine. It's just something to do with the LearnDash environment that we're using. So before we just start in earnest, I just would like to briefly outline what we would like you to achieve through the participation in the course. But as Kay suggested, if you have any other ideas, by all means do put them in the chat. And I'm just saying, yeah, and we can always try and change that a little bit. So by the end of the second day, because obviously we're in two halves, it's our ambition that you have learned and understood the STarT Back approach and how to how it relates to your everyday clinical practice. And, be it in primary or secondary care settings, whether you work in hospital, outpatient clinics, whether you already are FCP or community provider, OT, GP researcher, whatever is your area of expertise or activity professionally, we would like you to be able to use STarT Back in most efficient way. We would like you to understand its benefits and its limitation, and make sure you can use it to add value to your consultation. At the same time, it shouldn't really be a hindrance to the consultation flow. And this is something I've heard a few times from other GPs when they were saying actually it changes the way I consult. It's slightly difficult. It's sometimes clunky, awkward. So there are ways around it. We would like you to be reminded, I think, of the most important, I guess, feature or our skill, which is the communications really with patients. Okay, just to refresh some of those skills. In fact, this is what we're going to be concentrating on most of this morning. And of course, in the context of low back pain musculature consultation. Now, this obviously to a degree will be a challenge because we are meeting remotely, okay? But again, as we've already alluded to a degree at least, a virtual or remote consultation is probably going to stay with us. It's going to be part of our normal clinical routines going forward. So, we might need to adapt our consultation skills in that respect. And yes, as Kay mentioned, lots of ideas are coming through, including trying to teach patients how to evoke their reflexes using the mobile phone, which is, I think, it's another level. We would like you to, go away with some practical tips, life hacks, like the one I just mentioned, the management of patients with low, medium, high risk, persistent disability due to low back pain. Hopefully, you'll be able to formulate few kind of practical approaches for practice for yourself, really. Maybe, include them in your, what shall I say, armament of your clinical skills. And finally, we would like you to, develop awareness of the resources that are out there, and by this I mean really good quality evidence-based resources, okay, to support you in your clinical practice. So before we start for real, just a bit of housekeeping. So no talking about toilets there, because you should know where the toilet is, and there's not going to be fire alarms. But if anybody gets kicked out because of the internet connection, please just use the same link you used first thing in the morning to join us, okay? And on the topic of the links, during the communication activities, we will use breakout rooms. Most of you probably know what the breakout rooms are already, after 12 months of being grounded into it. For those not familiar, so basically, the way it works is that you'll be assigned to work in pairs, more or less in random, okay? And you will work in separate rooms by leaving this. So Laura, I have produced a list of names. Laura, are you going to share this link, or how are we going to?
Yeah, so whenever we're ready to go into breakout rooms, we've sent the calendar links to everybody already. I'll also copy and paste them into the chat here. If there's any problems or if people get lost in cyberspace, then just contact me and I'll ping you into a breakout room if I can. Yeah, so there is a way of automating it in MS Teams, but from the experience, if it doesn't work for one person, it breaks the whole meeting. So we are doing it a bit manually, but it's more reliable, more resistant in that situation. So basically, we're leaving that meeting, we're joining the the pair work using the other link, and after that, after you finish the task, you're leaving that meeting and coming back to the first one, the one that we're just sharing now, using the original link. So that's it. And I hope it makes sense. Last not least, feedback. Look, I appreciate, I know it's not an exciting part of any course we're all taking part. It's my personal plea to you guys, when you're feeling the feedback, just write what you did or did not like about this course. Just go on wishful thinking, spending spree sort of thing. Sky's the limit. Now, we've delivered several different courses already online, but I can tell you now officially, you are the official guinea pig of the first online STarT back course. So we would really like to learn from you guys, from what your experience is, as much as hopefully you will learn from ours, okay? And then we'll obviously try and iteratively improve the course. Right, so pretty much done. Without further ado, I will hand you over now into the capable hands of Katie and Stephen, and I'm going to talk about the principles of good communication. Virtual floor is yours, guys.
Thank you. Thanks for all of that, Adrian. Nice to see everyone. So let me just share some slides. Can you see that okay?
Yep.
Yep, lovely. So I'm going to talk to you about principles of effective communication, but at any point, just please talk up if you want to ask anything, or if anything doesn't seem right. You know, if you've got any questions, I'm happy to address them as we go through. Or of course, you could use the chat function if you'd rather write something in there. But the aim throughout these sessions is for them to be informal and collaborative. So please do please do kind of talk up if you need to. So we're going to first of all think about why we use communication as part of this training that we're delivering. And I just thought it'd be useful to highlight that communication's an important tool of sharing information between both parties. So it's not just about kind of a one side providing information, it's about that collaborative process of exchanging information, ideas and feelings with the purpose of creating a shared understanding. And I think that was just a really important point to highlight from the start, because we can often forget the real value of communication when we're in such busy clinics. Okay, so we're gonna, so like I was saying, communication is arguably the most important tool that we've got. So it's really important to think about how we can use it effectively, and we can flip into all different kinds of habits. So it's worth spending some time today thinking about what we do well and what we could improve on, particularly when we're using a tool like StartBack, where we're thinking about how our communication may change in different groups of patients that we see. So although we're using this session to highlight the principles of effective communication, it's a golden thread that we're going to talk about in each session that we deliver for you, so that hopefully you'll recognise the value of communication in each group that we're thinking of in the different stratifications. So there's lots of research to show the importance of effective communication too. And there's a whole range of reasons why. So the research has shown that we get fewer complaints, we get better adherence to treatment, patient understanding, improved safety in relation to less misunderstanding, particularly if we're thinking about things like medication. But then there's some really important areas that apply to what we're going to talk about today. And I'd just like to highlight that the point there about greater psychological adjustment, so that patients will adjust better to the psychological impact of what they're going through, and also are shown to be more satisfied with their care when communication is effective. So some good reasoning to use it well. So if we go back to thinking about our taught approach to assessment, it's often quite task focused, isn't it? We've got a limited amount of time and we try and get as much covered in that time as possible. And the result is that we often use quite quick and closed directive questioning, which can inhibit some of the more in-depth questioning that we might need to use to get a real good quality biopsychosocial assessment. And we might find that we slip into a primarily biomedical approach in the questions that we are kind of typically taught to use.
Katie, sorry to jump in, but I'm not sure if anyone else is seeing this, but I'm stuck on your Y slide.
Oh, are you?
Is everyone else? There you go, it's moved.
Is that better?
I can't see them at all.
Oh, can anyone else not see them at all?
I'm stuck on the research shows slide.
Research shows, yeah, that's the one.
That's okay.
Okay.
Yeah, I think we were all on
right.
Y.
Yeah,
I was stuck
that's
on
why
Y
I
as
keep
well, but
looking
now I
at
can
you.
see research shows.
Yeah.
Cool. All right. So that's what the research shows. So just give you a few minutes to catch up on that. So loads of different areas that covers. So Rebecca Fleck, hopefully you should see that moving now. So research shows there.
Okay.
Oh, if you just, there we go.
I'll move it myself. I can, if you say what number slide it is.
It's okay. I think I've sorted it now.
So we're still on the research shots, is that right, Katie?
Can you now see the assessment our taught approach slide?
No. I can move it forward myself.
So
I think myself, I can see it.
So I think what happens is if you try and do it yourself, you take control of moving the slides and it stops me from moving them. So if I just go back to taking the control and I've moved it on now to the assessment one, can everyone see that?
Yeah, we see the big screaming pill.
Yeah, so that
No.
that screaming bee is a physio trying to get lots of
bee. Okay, sorry. There are wings there. Sorry. Just to show I'm a doctor. Fair enough.
Oh, I've got now that the presentation's ended. Someone else is sharing. Is someone else taking?
Nicola, you seem to be sharing at the moment.
It would not be virtual input without these kind of applications, would it?
Guys, why don't we just, for the time being, unless we want to talk, that's what I just did. So please switch off your cameras, because we let you all have the full access to be honest with you, because it really works better, for the conversation rather than completely just us taking everything over. But then if somebody's overzealous to take, to participate, then that's what happens. So if we just switch all the cameras and microphones for the time being, unless you want to talk, and then we'll let Katie do her magic, please. Is that all right?
Yeah.
So
let me go back to sharing.
Okay, so we got the first title slide.
So you can see the title, and then we've talked a little bit about what communication is and why we're going to use it. So we're going to think about it through each session as a golden thread. And the reason being is that the research shows lots of reasons why communication is important. And really importantly in this situation, we're thinking about improving psychological adjustment to care and improved patient satisfaction. Okay, so now hopefully you'll see that our kind of taught way is quite a task focused, closed, biomedical approach that just where we just kind of want to get as much information as we can. Okay. So what I don't want really is that I just kind of tell you about all the areas of effective communication. I want this to be a collaborative process. And we want to hear from you about what's going well and how you practice effective communication. So we're going to have an opportunity now to go ahead and use those breakout rooms. So hopefully you will have the link for the room that you're going in, and you'll know the person that you've been paired up with to work with today. And so the task is to go away and have a chat with each other about how you currently practice effective communication. So think about the things that you're doing that you feel working well. And then when we come back, we will hopefully hear from all of you about those things and maybe think about anything that we're missing out on or any challenges, things that we struggle with. So I am aware of time, and so I'm going to try and keep it really quick and say we just meet for 5 minutes, but let's go 7 so we've got a nice round number. So if we come back at 25 past, and we'll hear back from everyone. So the pairs there are listed in the chat. Can you all see that okay? So what you would need to do is leave this meeting, go to the meeting that you've been paired up to, and then come back to this one at 25 past, and we'll have some group feedback. Okay.
Brilliant. Okay, I can see the numbers going down, which means that people are leaving and hopefully joining Imogen. Okay.
The issue is if you leave and then you lose the link.
I know what you mean. Laura? Oh, she's probably on this breakout class.
Is anybody left in this room? Because I'm happy to have a chat about effective communication if anybody's stuck here.
Yeah, me too here. I'm still here. There's no point of us joining for a couple of minutes indeed. We got still 23 people according to my counter here that are within this room, this chat room.
Okay. So should we sort of have a conversation?
I can only see 9 groups in the chat.
Okay.
Do I need to go back to my email?
Yeah, I think on your email, there is
It's on there, isn't it?
Yeah.
Yes, you're right. It's showing up now 13, and
I've got nine groups.
if you just go slightly higher up, there's another one with 13.
Okay, higher.
Yeah, so going back in time. Okay, I got 2 people coming in.
If anybody wants to have a natter with me, they're staying here.
Can you hear me?
I can hear you, Joe.
I'm trying to get into the meeting that's been set up, but I have to be admitted. Somebody needs to admit me to that meeting. I don't know how.
Oh, in the breakout room.
Yeah, it's giving me a message to say I need to be admitted into it.
Okay.
It's usually the first person that's there gets in and then admits the next one. It's a question of
don't worry, Joe. Don't waste your time on it now. We'll have a chat with us, shall we?
Okay.
That might.
Okay, I think it's happening with everybody. It's saying that we need to be the organizer to open the breakout room. Is yours still the same, George?
So, Adrian, do you want to try and sort that, and we'll just try and have a conversation. So, if you're in touch with Laura. Okay. So, Joe, what do you think works currently well for you in your practice?
I think reflecting back to patients what you've heard from them and summarising, the information that they've given you.
Yeah. So that's sort of talking back, that sort of checking what you've understood. Yeah, absolutely. Yeah. So let's go through some positives. So that talking back. Yeah. Anybody else want to add into that?
I think letting them talk at the beginning for a couple of minutes if they want to.
Brilliant.
They don't always want to, I find, though. Sometimes yes, no, and it varies person to person, doesn't it? Personalities.
Yeah, I think that's a great. I'm not quite sure who said that, but I think that's a great point. Doesn't the research say it's something like 90 seconds to allow somebody to kind of tell their story? And generally, they've said everything they want to say. Yeah, that's a great one. That's really
I thought about 2 minutes, but we're not far off in that, isn't it? Yeah.
Anybody else got any top tips? Anything that works well?
I think sometimes shutting up and stopping asking questions and giving them a bit of space.
Yeah,
absolutely, Joe. I think a lot of history taking has become an exercise of interrogation, isn't it, rather than a conversation? And if you turn it into a conversation instead of an interrogation, all of a sudden it works so much better.
Yeah, please keep chipping in. That's great. Great suggestion. Yeah, absolutely. I think sometimes we feel we've got a list of questions that we have to get done, don't we, to reassure ourselves.
Yeah, it's always cold. I'll open the window. No, I normally do anyway.
I think on the telephone that sometimes people start off quite reserved and less chatty on the phone than they are face to face, and then it's almost like they don't want the consultation to begin with, and then they start to talk and they start to just open up a little bit more. I don't know if other people think that about telephone conversations.
I think everybody's got different styles, haven't they? Some people are happy just to talk and talk and talk, and other people, yeah, they are a bit reluctant to start off with. I suppose you've just got to pick that up, don't you, as you're starting the consultation, really.
How much of the consultation do you think we spend talking, and how much do you think the patient spends talking?
Yeah, that's an interesting one. I don't know.
We probably talk too much and don't listen enough.
Does
But
it
then
vary?
I do think as well, some of the safety information, you know, when you want to clear red flags, there are some really clear things that you need an answer to, you know, to be clinically safe.
Yeah, so we have to persevere on those ones.
So there's that real balance between kind of creating that conversational style, but getting some of the information that's really crucial in terms of making sure you're doing the right thing for the patient. Yeah, absolutely. Yeah. How about the start? Where do you think the start of this communication happens? Where does it start to influence what happens in your experience of a consultation?
I mean, speaking personally, you know, just introducing yourself, asking the patient to confirm who they are. And I've had some great STarT conversations. Like one guy answered the phone last week and he said, well, this is from a private number. I don't normally answer the phone from a private number. And it was like, okay, well, should we chat now then? You know, he obviously had some barriers to actually joining in the consultation, but actually he wouldn't tell me his date of birth, but he was happy to tell me his address, and we got over those things, and then we had a lovely chat. But it was quite funny to start off with.
Yeah. But as a patient, I wonder whether your experience of that whole service starts as soon as you have your very first contact, and that might be a letter. So does the letter kind of, you know, create a kind of reassuring atmosphere, or it might be something patient starts very early in that process, doesn't it? And I think sometimes we don't give any attention to those kind of that sort of stage of the consultation, or that sort of element of communication.
I think sometimes they hear GP practice and they don't always hear physio, and start telling you about another problem that maybe they were expecting a call about, and you kind of need to just rectify perhaps where that introduction has gone a little bit wrong.
So Katie, you tell me when you want us to come back together.
Yeah, lovely. I'm just kind of keeping an eye on the numbers and seeing if everyone's back together. It says 46, is that right? Is that everyone?
That's pretty much, yes. The problem is that because there are many cameras at the moment, it's just kind of, there's a bit of a lag behind. Yes, it looks like, we didn't think about the fact that the first person that joins the breakout room has to be aware of having to admit the next one. It's the safety feature within, MS Teams meetings, so that, just a random person doesn't suddenly, join in and then starts abusing the whole meetings, as it happened initially in Zoom, if you remember, 12 months ago, although it feels like it's been ages ago. That's what happened. Apparently some anti-religious people were joining the religious meetings online and just throwing abuse. So pretty much every communicator now has this thing that people have to be admitted in.
So Katie, do you want to hear from everybody their thoughts on the kind of the communication elements?
Yeah, that'd be great.
Okay.
So I had some good conversation while we were here. So if anyone's willing to speak up and give us some thoughts on what they're doing currently that shows effective communication. I think Steve's going to be typing it up in the background, and then we can share and see what we've missed. Not that you're all going to miss anything, obviously.
Can I just add one thing before we go there? Can you see that?
How Not to Be a Doctor.
Yeah. This is the book by John Lohner. Okay, I'm just finishing it. It's absolutely brilliant. because it says how not to be a doctor. It's absolutely for everybody, although I think every junior doctor should read that. I think every clinician, and this is really quite a lot of that stuff, it's about communication. So this guy is a doctor. He's also he's got title in literature, and he's psychotherapist as well. He's really very hot on communication skills. And yeah, I mean, throughout the book, you can see, just listen. Just listen. Listen. People are telling us everything we need to know if we learn how to listen. And sometimes it takes these few awkward seconds of keeping quiet, which I personally find very difficult, I have to say.
I can't tell.
But honestly, I thoroughly recommend that book as a kind of adjunct to the course, really. How not to be a doctor, or how not to be a clinician, I think it should be called, really.
So shall we kind of highlight some folks? So Nicola, tell us how you've got, what you think works well for you in terms of communication.
Allowing the patient to talk for the first 90 to 120 seconds or so was, yeah, if they want to.
Great suggestion. Rob, I'm just going to pick on people for you, Katie.
Yeah, okay.
Rob?
Yep, hello.
Hello. Yeah. What works
Sorry,
well
what was
for
the
you
question?
in terms of communication?
So for me, I think the big thing is making it a conversation. Rather than what we classically is it turns into a bit of an interrogation, and it's all about me and answering my questions, and flipping it around in terms of a conversation for, actually, I'm there to answer your questions, and I'm there to help you and understand you. So yeah, making it a conversation rather than an inquisition.
Yeah, great. Katie, you give me the nod when you've kind of had enough of the conversation in terms of if you had feedback. Yeah. Denise?
I think in this virtual world, masses of encouragement for the patient that you are interested and validating what they're saying. And if they're finding it hard to tell their story, or they're tripping themselves up and saying, oh, various things, oh, you probably don't want to hear this or whatever, I just find myself dishing out tons of encouragement. Thank you so much. No, it's really, you're doing a great job describing it. No, I know now when you're describing location or whatever, if I need to, I give them little tips, shoulder pain, I talk to them about a lot. So, is it where your Boy Scout badges would be, or up more where your shoulder pads are, or whatever, but essentially trying to, as they need it, if they're struggling, just encourage them that they're doing a great job. Remember that you've invaded their home. There's a lot to be said for just helping them with the inhibitions which might be there. So I find that's the thing I've done most of this last year, encouraging them, validating them, making sure they know I'm interested, not because I'm putting on a show, but I actually am interested. So that's the best lesson I've learned, I think.
So that's a really nice thing, is what you've described there is genuinely being interested. So how else might you go about kind of showing someone that you're really listening and taking on board what they're saying?
I think having that that initial 90 to 120 seconds, whatever it is, the conversation at the start, letting them just talk is really important. And then that can kind of guide how you go, because you know what's important to them. And as you're asking questions, you can relate it to what they've already told you. So then they understand that you've listened to what they're saying, because you're feeding that back to them and letting that guide your questioning.
Yeah, lovely.
And I think just summarising and reflecting back to them what they've said to you in similar terms, so that you're just repeating, just to make sure that you have understood things correctly, or whether you've misunderstood.
Yeah, there's a lot to be said for taking on their wording, isn't there? And instead of just kind of using a script.
The other thing I think is being careful not to write too much down while you're on the screen, because otherwise it doesn't look like you're actually paying them attention. I've had a couple of feedback about that. I think I do too much writing while they're talking.
I just didn't quite get that. So what was that?
So when you're taking notes, making sure that you're maintaining eye contact across the screen if you're doing a video consult, to increase that interest, but also because they can't see what you're writing down, it's making sure that they're aware of what you're doing and why.
Yeah, Yeah, so if you do need to type something, as if you're doing kind of a video or a telephone consultation and you need to record some information for your memory, then it's important to set that up for the patient, isn't it, to let them know what you're doing and why you're doing it.
Definitely, especially reading from the notes. If you need to look away, because the screen or the notes are somewhere else, it's just reassuring them you are listening. You're just trying to do two things at the same time. And probably in terms of computer, make sure when you're talking to a patient, when you're looking at the patient on the screen is just underneath your camera. So it happens to me a few times because I have two screens, and sometimes I have patients on the other screen. So basically, it looks like I'm completely ignoring my patients because I'm looking away. That's where my camera is. That's what I. So it's worth making sure the technology also is right, because it just really can be inadvertently quite rude.
Yeah, so this kind of virtual world we're now living in added a kind of spanner in the works, hasn't it, to our normal approaches, and we've had to think about things a little bit differently. Are we remembering kind of the basics where we would kind of introduce ourselves with name and job title and clarify the patient consent and things? Great. Can't do handshakes now, can we? So building rapport can be a challenge. How might we go about doing that with a patient now?
I think being human with them and having a bit of humour, if appropriate, and relating to what they're saying to you. The impacts that their symptoms are having. How would that affect you? How would you feel if you had those problems? So being personal and a real person.
Lovely, thank you.
I think also acknowledging the fact that we are in strange times, and just having a little chat about, oh gosh, it's a bit funny, isn't it, being on this video call, but let's go with it, and sort of allowing them to kind of struggle with that a bit if they are struggling with it, and kind of saying that that's okay and that we appreciate that it is weird.
Yeah. So are you recognising any challenges that are coming up, things that you're struggling with?
I had a patient yesterday whose English really wasn't very good, and you could identify really early on in the assessment that she was struggling to understand what you were saying. And I switched to video call really quickly, much earlier on than I would do normally, because normally I tend to do a subjective assessment by telephone and then swap over. But I switched to video call within a few minutes. And it made such a huge difference just by kind of being able to see people get some body language, demonstrate on your own body and things like that. And she identified at the end, she thanked me. So she said, oh, thank you for persevering. I'm sure she didn't say persevering, but thank you for being patient. I know my English isn't good. And I said, yes, that's why I switched to video call early. And she said, yes, I've only been in the UK for 2 years and I am trying. And so she really acknowledged that actually, trying with communication, and it made a huge difference with her, because you could really get a much better feeling of her back pain and her symptoms by video call rather than trying just by telephone, I think.
Okay, great, thank you. Shall we, Steve, have you managed to type up some responses there? Should we share that if you've got it and see what we've gathered together, and if we've missed out on anything?
I'm frantically typing, trying to keep up with all these good ideas. Okay, let me just try this.
Just whilst we're waiting, just a comment, I think, is being on the other end of the line, and having, I've had a couple of my own GP consultations now, just rather being the patient.
So kind of being in that situation yourself, recognising.
Yeah, it's a learning process.
Yeah.
So, can you see that, everyone? Or should I say?
Yes, we can see it.
Yeah, so not sure if it's clear, but I was just trying to put it in some kind of structure or some kind of order that might relate to the consultation as it goes through. But someone mentioned, I think before, the breakout rooms. came back about it starts really from the information that's sent out in the appointment letter and what you're communicating. Certainly, we can relate to this in our service. Our appointment letters would go from the trust rather than from our specific service, and so often the information that the patient receives before your appointment can be in some ways misleading. So you know, they can have just a sector like rheumatology at the top, or they could be surprised to be speaking to a physiotherapist rather than a doctor, or perhaps a psychologist, really. So that information seems really relevant. I think that was said before we came back. Also answering this no caller ID. This is something, again, I think that we can relate to. We've recently got some Trust mobile phones that we've been using, and I think our DNA rates on the telephone appointments has dramatically dropped since we've started sharing our numbers with our patients. Someone mentioned, I think, as well, hearing the GP practice and not the physio, so they start to tell you about perhaps other problems. So just clarifying exactly why you're calling, introductions, importance of those basics, just making sure you introduce yourself so that people are aware. I think it's even more important on the telephone or video, because if someone's coming to your clinic, they know specifically, you know, where they are, who they're there to see, as opposed to just someone popping up on their telephone or on their screen. So it's quite intrusive. We're going into their environment rather than the other way around. So it's nice to introduce. Someone mentioned building rapport, so being human, humor if appropriate. That's can be a tricky one. There's probably a conversation to be had around that. This is really interesting. I think this is something that most of us are now fairly familiar with, this letting people speak for the first 90 seconds or so. I think there's quite a lot of research now about the importance of that. And when I first trained it didn't seem to be a thing, and we have a tendency, don't we, to jump in, and we're all pressured by time, so we have a tendency to jump in and speak. But often this will be the first time that our patients have ever had the opportunity to talk and tell us their perspective on their problems. So it can be really helpful just to listen there. I like the idea, I can't remember who said it, about making a conversation rather than an interrogation, and I think Katie will probably talk a bit more about that. Really like this idea, you know, not about me, it's about them, and sometimes that can get lost in with our time constraints and other pressures. Encouragement and validation. I sort of bundled together compassion, because lots of people were talking about, you know, putting themselves in the patient's shoes and trying to sort of see it from where they're standing. Personable. You know, I think physios are generally really good at that, but it tends to be important. Feedback to them. So again, Katie will probably talk more about this, but this, you know, this idea of hearing versus listening, you know, and understanding what they've said and doing that in a summary and reflecting back to them, but taking on their own language rather than using sort of scripted stuff that we've learned perhaps. And then, you know, things like eye contact. This is massive, isn't it, at the minute with our online consultations. In fact, I set my camera up this morning for this meeting and had a laptop on the side, and when I was chatting to Katie about it, she was like, oh yeah, you know, your camera's on the side, not in front. And so even after doing this for a whole year, we can still make these kind of basic mistakes. Yeah, so I think that was all I got. Is that okay?
Yeah, that's great. Thank you. Thanks everyone for your input. It's really good to hear where you're at with kind of communication skills and what you're currently doing that's working well. So just to kind of clarify a few points, I think it's really important that we set our agenda from the start. So that kind of fits with what we were saying about introducing ourselves and checking the referral route in is what is for us what the patient expects it to be. And someone just posted there about kind of finishing off the conversation nicely. So summarising what's being said and clarifying that everything's being covered that the patient expected. So let's just go back to, does anyone got anything that they want to add in there?
Yeah, there is a couple from Rebecca, for example, if you can see. I'd like to know if my past have taken over my patients when I was sent to shielding jail.
Yeah.
The impression that patients felt I've tried my best for them or listened to. That feedback would be important, as well as self-assessment. Yeah, I couldn't agree more. And I think really the fact that we are now struggling with the video links is effectively the consequence of the choice we've decided not to restrict communication between each other. Okay, so it's not just us talking to you guys and you not being able to comment or see each other. It actually works because the chat is red hot, as you can see, and we're interacting. So this is basically what it is, isn't it?
Okay. So thinking then about a biopsychosocial assessment, we're going to be considering all areas of those three areas, aren't we? So we're going to be thinking about the medical, the psychological and the social to help us get a better understanding of where the patient's at. And there's various ways of doing that. So we're going to try and use non-directional questioning. So we're going to try and be open, get the patient to give us their information rather than us just kind of predetermining our agenda and going straight down into a closed line of questioning. Of course, there's information that we need to know, but we can also just kind of try and be a bit more open with the way we receive other areas of information. We want to be using listening and hearing. So quite often we might get ourselves into a situation where we're kind of taking on board the information, but not really hearing how the patient's putting that across. And it's important that we do really hear what the patient's saying, because there can be a lot of underlying information that we're missing out on if not. Okay. So we've got to really consider the patient's cognitions, their emotions, their behavioural responses during an assessment, as well as just getting information in a kind of didactic way. We also want to think about the terminology that we're using. So the words that we use can have a huge impact on the way patients are thinking or feeling, or their beliefs that they've got about what's going on for them. So we want to be cautious about the way that we use our terminology, and just kind of think about how that comes across from the patient's perspective. And going back to Rebecca's point there, really, that we might want to get some feedback on that in the moment. So if we kind of are aware that we're using terminology we might be quite used to, it might be worth asking the patient what that means to them. Because it's good to clarify any misunderstandings, isn't it, from the start. It's also really important that we build up trust, empathy and compassion, and it sounds like you guys are doing a great job of that with what you've just talked about. And we'll certainly try and develop our skills in that as we go through the presentations over these couple of days that we've got with you. Okay, so is there anything that's taken anyone by surprise or anything that we're missing there? Okay, so we're going to think then about how we might make this specific to a pain consultation. So what's really important is that we kind of shift away from that kind of expert and patient relationship. So the patient is their own expert, and we should really kind of take on board what they're saying as fact and not kind of judge that in any way. There's times where we can slip into that expert role because part of our role may be giving information, but it's really important that where we can, we listen to the way patients are describing things for them and really trust the information that they're giving us. We want to try and use open questioning as much as we can and allow time for the patient to talk about their experience. Okay. What's also important to note is that talking about pain can be really difficult, can't it? It's a very emotional process for patients, and we want to really kind of think about whether we are asking the questions that patients will be able to give us the information about and will be able to respond to. So it's important not to ask how someone's feeling if we're not able to kind of listen to that and respond. We might be hindered about how we feel about asking those kind of questions if we feel uncomfortable or helpless about the information that might come. So it's worth just kind of checking in with yourself what you're addressing in that pain conversation, and if there's areas that you're kind of missing out on, and reflect that back to the patient. You know, you might find that there's times where you can halt the conversation and ask a little bit more, or let them know that there's the kind of time to cover that isn't at that moment, and come back to it if it would be more appropriate to. Metaphor can be useful when we're talking about pain, and we'll perhaps cover that a little bit more in another session. But it's recognising the time and the place for that, and not just kind of bombarding patients with information that they might struggle to relate to. And like we mentioned earlier, just trying to avoid that scripted approach, but more so using those open and responsive questions. So there are things that we may get used to doing that can inhibit information that patients give. And quite often this is well-meaning, but it's worth just seeing if there's anything here that you recognise as being a kind of pitfall of any assessments that you do. So again, that kind of risk of over-reliance on closed questioning, or leading questions, or just trying to get as much done as you can and therefore not picking up on cues that patients are giving you, that they're perhaps not being quite so direct with. Someone mentioned earlier using humour, and kind of backed that up with if it's appropriate. So it's important to know that making light of a situation may not always be the most appropriate thing to do at the time, and it's using humour in the most kind of caring and compassionate way, isn't it? Also, in that kind of endeavour to get as much information as we can, we might go down the line of asking lots of questions at once, or we might find that the way that we phrase something initially we're not kind of happy with, so we'll phrase it in a different way and ask a few questions. The patient might then feel unsure of which one they're answering, so it's worth just kind of recognising where we want to kind of pause and allow time for the patient to respond to each question. And also just noticing the kind of risk of premature advice or reassurance, because that can kind of hinder how much the patient opens up, or how valid they feel that advice and reassurance is. So just kind of recognising and responding well to a patient in that way. All right. So you may have come across Socratic questioning before. So this is an approach which is about kind of this open and investigative type approach to questioning, where we are aiming to really improve the quality of what we're asking the patients about, encouraging reflection and unraveling the kind of values and beliefs that patients have got when we're asking them things. So the different types of Socratic questioning are listed here. So we might want to kind of clarify what patients have said. So again, worth doing in the moment rather than kind of letting something pass without you addressing it. So this might be when you say whatever it is, what do you mean by that? So that we're finding out a little bit more about what the patient belief is about the thing that they're communicating with you about. We may also feel it's important to challenge any assumptions. So I'm sure you've got lots of examples of assumptions that patients may come up with. We might want to just ask a little bit more about that. Why is it that you think, or what is it that you think is important about that? Or what is it that you've been told about that area? You might want to gather some information about where they've got their reasoning from. So it might be worth thinking about approaching this sensitively. So if they've been given some information that they think is a well-evidenced source, it's just, again, kind of finding out a little bit more about that. So can we validate what you're talking about there? Can we think about where that information has come from and why it's important to you? Thinking about alternative viewpoints. So how has someone else responded when they've been told that? Are there any other ways of thinking about this? Implications and consequences. What are the long-term implications of this might be a question to use, and also challenging their question. So when a patient's asked you something, you might want to just kind of find out a bit more about what they're really getting at with that question. So why is this important to you? What is it about this that matters? I'm aware as I'm talking there that I'm asking kind of whys, and that can sometimes be not the best approach to use when we're talking to patients, because we're asking those why questions can put the patient in a defensive spot a lot of the time. So using questions that more begin with what and how and when kind of give us that kind of explorative approach to a question, rather than putting that kind of defensive question in ahead. So the plan now was to go to another breakout session and have a think about using some Socratic questioning. I'm not sure that's going to work very well in view of how the breakout rooms have just gone. So I wondered if we could just be brave as a team working together here and open it up for everyone for us to talk as a group, so that if you kind of gone through your assessment and a patient then said, I think I need a scan, which is a question we often, or sorry, a statement we often hear from them, how you might use communication skills to address this. And could we think about using some Socratic questioning to address this in a way that brings out that effectiveness of communication? Just reading these chats. So what do you think? Are you guys happy to talk as a group?
Well, we can try. I wonder, now that we know that the first to arrive into the breakout room has to admit the next person, we can try for 2-3 minutes, but yeah. if it doesn't work, just don't linger on and come back to the main room, shall we?
Yeah. All right, Laura says
to click, admit the next one. If that doesn't work, just come back and then we'll have a chat here, I think.
All right.
Being around.
I think Laura just said that privilege has been updated, so I think
it should be okay now. But
okay. Yeah, give it a try, and then we can always come back and have an natter, can't we?
Okay, so just use those links that we were sent by Laura initially.
Yeah, people are leaving.
Okay, yeah. I think we're staying here, guys, aren't we? Yeah.
Sorry, could someone put the links back in the chat? When I came back in last time, my chat got deleted, so I don't have them from before, and I haven't got the original email.
Oh,
sorry.
Well, there's been a lot of chat that I had to scroll up quite a lot of times.
Yes, that's massive.
Really good.
But I think honestly, I've been on a couple of bigger meetings where, for the sake of the internet connection, it was really very much one-way system. So just the presenters were able to talk.
Yeah.
And I have to say, it was one of the worst meetings ever. There was completely no interaction, and
Mark, have you got those pairings again? Is Mark gone? Yeah, Mark's left. Yeah, okay.
I think, Adrian, as well, it's reminding ourselves that what we're doing here is what we would normally do face to face, isn't it? So if we were face to face, it's not a lecture as such as it is. It's very much about that kind of thing. It's hard to bring that into the online space.
How I guess what we've still got folks with us in the room, so I think
it's working from home, and therefore I guess.
So do you want to start some conversations with the folks that are left with us? How many folks have we got left with us?
So I got number 17 on my screen. That's
so we've still got quite a few folks. Okay. So Katie, are you happy to steer the conversation with those that are left in the group? I think people are saying there's still some issues there. So
yeah.
It's done screenshot.
I'll start. I don't mind starting us off. I don't mind being the.
Sorry, I was just reading I was just wondering what the image was that someone had posted it. Can't see it.
The question was about I want to scan a patient that.
Yeah, and how we might kind of address that. So maybe thinking about how we might ineffectively address it. So in that kind of closed approach may not work so well. And then the difference then of using a Socratic kind of open explorative approach to that. I don't want to give away all the answers. So it takes someone to be brave to talk this through with us.
Go for it. Who've we got? I'm going to have my cursor. Rob, go for it.
Sorry, I only just came back in the room then. What am I going for?
We just put you on the spot. Okay.
It's like when you walk in late in a comedy club, you get picked on.
Yeah, absolutely.
About it, Rob?
I think it's great.
That's always the same answer, isn't it? I agree.
Yeah. Okay, so if we think about when a patient will say, I think I need a scan, so particularly in this kind of low risk group that we're going to talk about today, we might just kind of brush that off and get used to maybe an ineffective, I don't think you need that, which may be quite closing for the patient. So could we think about how you might explore that in that more kind of Socratic, open questioning type way?
Yeah, absolutely. I'm always really intrigued as to what they think the scan's going to lead to, and I think having that conversation about let's have a chat about that. What do you think the scan's going to do, and where's it going to go? What does that open up that you don't think you'll get without it? And often that leads to lots of conversations then, doesn't it, about their sort of beliefs about back pain or whichever bit of the musculoskeletal system we're looking at, and that how biological or biomedical they're thinking about this, and their understanding of what actually can and can't be done. And often that opens up a question of, okay, I get that you understand that. I'd like to understand why you think that way.
Yeah.
And let's have a conversation about it. And often it's just because, well, I've done everything else, or it opens up all of those other questions that the patient has in terms of, I see this as the answer to my problem, but I don't know why it's the answer to my problem. It's just because everybody says a scan will answer my problem.
Yeah, great, thank you.
We got Joe raising her hand.
Has everybody seen the Macquarie University information on why? So it answers that question. It's a patient information leaflet. Why will an MRI? Why is an MRI scan not helpful for back pain, basically? So there's a really good leaflet that they've produced.
I've not seen that.
It's good.
Sorry.
Yeah, I mean, it's on the internet. It's Macquarie University in Australia that have produced it.
Yeah.
Yeah,
so has anyone got any other questions they might want to ask a patient? So Rob there talked about asking why it was that patients felt a scan was important. What other line of questioning might we use?
I'm just kind of Yeah, it's maybe interesting to say, because I may be raising my hand as a potentially somebody with fault, because you are usually receiving the patients from me, from a GP. So if I, just to get rid of the patient, say, look, I'm not sure what it is, I'll send you to this fancy, all singing, all dancing, physio, MSK, and then we'll scan you. Okay? That is an absolutely awful way to say, awful way to consult, but unfortunately that happens occasionally. So how would you deal with a patient that either through this sort of management by a GP or referrer to you, or through misunderstanding, come and will basically say, look, the previous clinician that consulted me told me you will give me a scan. And let's say be as combative as I'm trying to be now. How would you deal with this? Imogen, I have you really big on the screen, so you're coming up now. For some reason, you're occupying half of my screen. The mute.
That's
okay.
How
would you deal with a patient like that?
So it's always a really awkward time, isn't it, when they're quite either they've been misled at some point or they've misunderstood the plan going forward, and then you're kind of the person that has to answer those queries and questions, and it's really difficult if you don't feel a scan is appropriate. You then have the challenge of trying to alter that patient's thought processes and trying to almost win them over, if you like. So similar to things that I just caught the end of what Rob was saying before about, I tend to then, rather than saying, well, that's not appropriate straight away, because then there's just going to be a huge barrier between you and the patient, and then they're probably not on board. So I try and then unpick a little bit about, okay, why do you feel that a scan is going to be appropriate, and try and get their thoughts on it. Is it just because someone suggested it, or do they actually feel they need it? They're worried about something. Could I reassure them about their exam, that I'm not concerned that there's anything sinister going on, and give them that reassurance? And that might be enough for somebody to see, okay, this isn't really, really serious. Maybe I don't need a scan. And then I like to talk about things like that sometimes we find things on a scan that aren't particularly helpful, and actually it can be quite misleading. So sometimes I talk about, if we scanned lots of the population, we may find things on a scan, and that might not be the cause of your pain. So I tend to kind of go down that route and try and unpick it nice and gradually, but it is a real challenge, and I find that it's a real difficult one to unpick with the patient.
Yeah, that's really nice there, Imogen, because you've opened up by asking the patient why it's important to them and what they think would be different by you doing that. But then you've really kind of balanced that around what the limitations of scans are. That sounds like a really nice approach.
I think it is very tricky, especially if the patient's had lots of other biomedical investigations for other health problems. And obviously when you're investigating the source of pain, that's a lot more complex than identifying a pathology or a disease process. And I try and explain to patients that the pain systems are a lot more and the human body and the human person is so much more complex than the technology that exists, and a scan is only looking at a very small part of a massive system that might be involved in their experience of pain.
Yeah, lovely, thank you. How does anyone feel any worries about using this kind of Socratic approach to questioning? Has anything coming up for you that's making you think, I really couldn't do that in a clinic environment?
There was something in the chat, Katie, maybe worth picking up on. Someone mentioned about whether it can come across interrogating, or perhaps how we manage patients that avoid the question. Is there a different way in, a different approach? Maybe worth a discussion.
Yeah.
Who was it asked the question? That might be best to hear from them.
I think I asked the question because often you are trying to find out, you have a minimum amount of clinical information you do need to get from a patient to be safe and to be confident in the way you're managing them. And sometimes patients hear the question, but they don't really no, they listen to the question, they don't hear it, and then they, you know, have a lot of things they want to tell you, but completely irrelevant to what you're actually trying to find out. So that can be a quite tricky position to be in. You know, the balance between you're really trying to understand this problem, make sure the patient is safe, and to help them in the best way, when they're really ignoring your questions and giving you a lot of other information.
Yeah, so it's worth kind of thinking about why they're doing that. Quite often patients want to get something across to you, don't they, if they're doing that kind of approach. So you can be open about what you've just described there and say, you know, that there is some information that I really do need to get from you, but I'm hearing that you want to give me some information too, and just kind of bringing out that conversational element to it where you're collaborating, you know, you're asking about what's important to them, but you're also just kind of bringing them back to what you need to know that's going to help you clarify which direction you send their input in.
I think I was asking about it, that it can become a little bit more of an interrogation, that it's a very different way of questioning than a lot of potentially GP consultations go for asking a patient what they think. There's still the very much the inherent patient expert conversation that they would be used to, and it's just different for a patient to actually come into a newer way of having a consultation for the patient. So it's quite alien for them, and so that's why I think I was asking the question, that it can come across a little bit like an interrogation of actually getting them to think about something, whereas they haven't had to do that before. A lot of patients are coming to have all the answers given to them rather than to have to do any work themselves. So that's where it's balancing out how much of an interrogation versus allowing them to open up and think about what they're actually asking.
Yeah, I think you've got to kind of set the scene, haven't you, about what you expect from the consultation at the start. So sometimes even just clarifying to the patient how much time you've got available can be a useful first step, because quite often patients will think that we've only got the amount of time that a GP has got and feel that need to kind of rush and impart everything that they can in such a short space of time. So you might just want to say, you know, it's important that I hear about how this pain's affecting you in lots of different ways. So I'm going to be asking lots of different questions about this. If there's things that you ask, I ask that you don't want to answer, that's okay, but I'm going to give you the opportunity for us to really explore what's been going on here. So just giving them some context might lessen that feeling of interrogation, because if we just go in and we're just kind of firing lots of questions, that would probably feel that way. Whereas if we're setting the scene and allowing time, but also justifying why we're asking what we're asking, it might just help the patients kind of open up.
Can I just play a bit of a devil's advocate here and ask you, how do you deal with the questions? Because obviously, yes, we are all more and more proficient at using this very open and, you know, partnership-like approach to patients, but there are still quite a lot of patients that are actually quite used to this paternalistic expert-patient relationship. So you coming over, you're starting asking the questions, you're asking you, what do you think that might be, you know, why you're here, what is your worry? And they just turn back to you and say, you're the clinician, you tell me. I thought you're going to be the expert.
Yeah.
How do you deal with this sort of expectations that everything will be dished out?
I think that's a really good question, Adrian, because a lot of patients are expecting. They say, like, I had a conversation yesterday where the person just effectively said that you're the expert, you tell me. Mm-hmm. So.
And there's a time.
I think you've got to roll with that to some extent, don't you? Yeah. You just sort of have to go. You put that into your schema of understanding of that particular patient. So that's a unique communication issue, and you just stick it into your communication strategy. Mm. So if they have a very baked-in view about causation, and their view of causation is that it's a mechanistic reductionist approach that's going to be required in order to elucidate their problem, and that's sometimes what you have to roll with to that extent, and see if you can unpick it as you go along, and maybe accept that you can't always.
Yeah, I think unpicking that is a key part, isn't it? So finding out what it is that they want information about, because we can find ourselves slipping into that expert role without really thinking about it, and it might be premature or it might be unnecessary, but you're right, there's times where it may be needed. So asking permission might be a good thing to do. You know, it sounds like you've got some questions about this. Is it okay if I let you know a little bit more about that? And that might open up the conversation. But I think what you were saying there about unpicking is important, because you're going to find out a bit more about what their beliefs are about what the role is and what you're aiming for in the session.
Can I jump in as well? I think in terms of answering the question about how you might manage that, for me, it's really about striking a balance of what it is that you believe will be effective in combination with what it is that they're looking for, as you just said. So, and what I mean by that is, the temptation is there for us to revert back to this expert-patient thing, and people say, well, you're the expert, you tell us. I personally feel like it's worthwhile at that time really trying to just slow the conversation down and finding a different way of using your questioning to explore, you know, I guess the foundation of their views in that. And that's what most people will think, because that's what we've been conditioned to believe. But just really going back to the idea of exploring the importance of why their views are important about their healthcare and how they are the expert in what will be most helpful for them. And so for us to effectively to help them, we need to know more about where they're coming from. And so the temptation, I suppose, is just to go along with that approach rather than really keep a focus on the why, you know, and get into that conversation a bit more. Hope that makes sense.
Rob's got his hand up.
Yeah, can I just add into that? I guess this comes back to some shared decision making work that we've been doing before, you know, and it's that recognition that there are two different types of expertise in the room.
Yeah.
You know, the bottom line is we are experts, but the patient is also the expert in their life, and it's about putting those two levels of expertise next to each other rather than one being hierarchically better than the other, and enabling the conversation to appreciate both sides of those expertise and bring them together to find the right solution. So yeah, I couldn't agree with you more, Stephen. I think it's about making sure that we respect those two levels of expertise and we ensure that both are brought to the table.
Rob, I agree with that entirely. Just to be able to empower the patient to acknowledge that we are the expert, but also to empower them to say that they are also the expert as well, and actually trying to express some vulnerability of ourselves and say, yes, we are an expert, but we need to be able to be, can you help me to understand you as your expertise and bring whatever you've got to the table, and I'll bring whatever I can to the table as well, so we can share together both of our levels of expertise to come to a decision at the end of it.
And the feedback generally is it can be such a refreshing thing for a patient to hear. You know, it can be uncomfortable and it can be certainly unexpected because it may be the first consultation that they've had that goes along those lines. But I think as physios, we want to fly the flag for that approach and to really go some way to changing the mindset and the beliefs of what a health consultation should be like, especially in pain where, as someone mentioned before, you know, we're talking about very complex workings that more often than not cannot be solved in the same kind of biomedical approach that we might use for other structural things. So it's, yeah, perfect, great conversation.
There's a very good comment, you know, in the chat from Tony in Malaysia. I really like this. I would normally say that different person may have different thoughts about what they're going through. So I would like to know if you have any. I mean, how open and welcoming this question is.
Yeah,
I think it's brilliant.
Can I just say as well that I think the patient is on a journey, and I work mainly in FCP. I may have a conversation that goes along those lines of, you know, we are equal experts in all this. The patient may completely disagree with what we're you know, what we're discussing, you know, they're expecting to be given a solution to the problem. However, they are on a journey, and if you have an agreed outcome of the, and it might be, look, I'm going to refer you into the pain management program, you know, that consultation might just be parked in their head. They may not necessarily agree with you. They're keen for a medical solution. However, on their next step of the journey, that previous conversation may count towards a lot, and they then may go on that journey and engage more. So I think just necessarily because they don't necessarily agree with you at that time, that's fine, but they will potentially be seen by someone else at a later date for a further discussion, and hopefully what you've imparted and discussed with them may aid their onward management.
Absolutely, and we'll be covering that a little bit more in the session where we talk about the kind of low risk group. But one of the aims, obviously, in that first consultation is to try and prevent them becoming chronic. I can't say that word. So that what we want is that we're giving them the best and the most effective information at that time, don't we, to kind of shape the path that they'll take after that session. Has anyone got anything else to feedback on this point? I'm just conscious of time, and I'm wondering if now's.
Have your hand up, or have you just?
I think. Is it Joe? Have you still
It's a
got your
legacy hand, isn't it?
Yeah.
Okay.
So the other thing to say really is communication's a skill, and one that we need to continue to practice in. And it's always worth getting feedback, and that may be from patients. So we may get that in session where we ask, you know, have I addressed everything that you wanted to be addressed during the session? Is there anything that you need further information on or needs clarifying? You may find that you get that from outcome measure tools that you're using, but it may also be worth kind of putting yourself in that tricky situation of doing some peer feedback. So either getting a colleague to supervise a session with you, or doing it remotely from a patient. So having some training where you're kind of working through these kind of questioning techniques as colleagues, and getting some feedback on the way that you're communicating with patients is really important, because it's a really useful skill that we've got, and one that we need to continue to practice and evaluate. Okay.
Can I add there, Katie, as well? Thinking about we've talked a lot about the sort of verbal communication, haven't we? So if you write to patients at any point during their kind of their session with you, whether it's for information, I would kind of encourage us to think about how we write to patients as well, and what language we use, because sometimes that can be equally as destructive if we've kind of put, you know, made all the effort in the face-to-face or on the online consultation, and then the letters are full of jargon, and you know it's a real challenge. And we've seen, you know, we're all guilty of it, and I've seen some corkers in our service, you know, so that's worth us kind of thinking about as well. Thank you.
Great. Anyone else got anything they want to add in? Well, thank you all for your input. We've got communicating as a team, didn't we? And we've got the chat going as well, so that's really good. I think it's perhaps time for a bit of a comfort break. Is that right, Emma? I think I was trying to move ahead a bit of time because we've got a little bit less time in a couple of sessions earlier, so.
Okay. I mean, only 9 minutes ahead, so I think it's absolutely fine and justifiable to move the comfort break, especially as our colleagues, you know, in Malaysia will finishing much later than us. So I think it makes sense. So I mean, it's 10:22. Okay, we're supposed to be meeting at 10:45, which would be 6:45 in Malaysia. Shall we make it 10:30? Is it too short? 10 minutes? No? Is enough? Okay, so 10:30 and 6:30 respectively. All right, so we got 8 minutes for a cuppa, maybe a second breakfast. Okay, brilliant.
Thanks, Katie.
Thank you.
Thanks, everyone.
Nicholas. Oh, there we go.
Everybody got a brew?
Yeah, and of course a bit of exercise.
Yeah, need that, don't we?
Yeah, stretching all bones.
We definitely need to do a bit more fizz.
Mm-hmm. Going on the bike tonight, Kay?
Well, I went on Tuesday. I think it's going to be a run tonight, I think. Not that I run very far.
Somewhere around, you never know. No, I'm not going that long. That far. Okay.
Yeah, but Katie and Stephen back.
Yeah, here.
Hiya.
Yeah, I'm here. Should we give it a minute, Adrian, or is everyone back?
I think it's just, I mean, I got 32 plus, just a few more. I keep admitting people, so just give it a minute. And we can crack on. What's that sound?
That sounds like a truck somewhere. Well, I've just had some chocolates and wine delivered to the door. How nice is that?
That's nice.
That sounded like a Harley Davidson. Oh, look at those.
Oh, wow.
Ooh. See, unfortunately, that's one of the drawbacks of virtually. She can show it to us, but she doesn't even have to pretend she wouldn't want to share.
Share Belgian contemporary shop at Marks and Spencer's, no less.
Very nice.
Very nice.
All right.
Was that something you ordered yourself, Kay, or was that was it a surprise?
I've made that mistake before. Have you ever done that? Ordered some flowers. I thought, oh, this is great. Oh, I ordered these for somebody else and they've come to the wrong address.
Oh. Right.
Yeah, I'll be quiet.
Okay, shall we start? Because if we are to kind of gain on that time we've just earned, then we may as well start. And I think it's pretty much everybody. I'm not admitting anybody else. So yeah, welcome back, everyone. Hopefully you had a bit of a refreshment. Yeah, a cuppa. Yeah, some of us found wine and chocolate. Good for them. Yeah, so the second part of the morning, we'll have two more activities. So the first, Katie and Stephen, will talk about the principles of goal setting this time in living with pain, which, this is quite often difficult and, challenging conversation to be had. That often kind of sets the tone of the whole kind of patient-clinician relationship. Sometimes it's years to come, isn't it? It's not necessarily even that particular clinician, but any clinician the patient sees about the pain in the future. So that's the first part, and the second we will concentrate on applying the principles of good communications and goal settings in low-risk group particularly. So the biggest one, that's the bread and butter that we have every day. So that was initially supposed to be facilitated by Katie, Stephen, and me. Alas, I will have to leave you just before 11 o'clock. So I'm really sorry. Although I'm sure there's meeting somebody else, I'm sure you won't be missing a lot by not having me around. And then the close of the day and the final reflection are in the hands of Laura. And then we'll hope to complete the first day. Well, initially it was for 10 Malaysian time, but hopefully we'll finish slightly earlier than that.
Yeah, and it's down the bottom there.
Which is going to be hopefully around 10:30, 12:30 or so. All right, so let's crack on.
Okay, thanks, Adrian. So first of all, guys, I think what we've done this morning has been brilliant. That collaborative view has been really, really nice to hear what you're thinking. We hear some really great stuff. So let's continue in that vein. Certainly don't want to listen to me talking for the next hour. So we'll try and make it as conversational as possible. I'm just going to try and share this.
Why can't I see anybody?
I'm hopeful.
Oh, I can see some now. Yeah, I think so.
I think Nicola, we can hear you, Nicola.
Okay, I can hear you. I just couldn't see anybody. I can see Stephen, but that's it.
Oh, unlucky. Can you see the slides now, Nicola?
Yeah, I can see the slides now. Yeah, Nick's come to help me. Yeah, it's just, I think it's the computer. It's just the connection. It's a bit hit and miss.
All right.
Yeah, but thank you.
Yeah, no worries. Okay, so principles of goal setting and why that's important. Let's have a look here. So I'm going to jump straight into the conversation and try and get your views really on this question. So why do we set goals? So as a physiotherapist, why are you setting goals with your patients? So who wants to jump in?
For outcomes?
Yeah.
To identify the things that are important to them.
To make it as patient-centered as possible.
Yeah, like that. That's really important.
And to be realistic as well.
To show them that they're improving rather than just pain is not always a good outcome measure, but to be able to give them some functional changes to demonstrate to them that they are seeing changes.
Yes, so changes in function.
Yeah, so improvements in function, whereas they may only see the only outcome measure being pain improvement, whereas just try and broaden their understanding of goals can be greater than just pain improvements.
Love it. Yeah.
I think also relating to that is also making sure that their goals are realistic and having short-term, medium and long-term goals if possible.
Yeah.
And so they know what to expect as well with a specific pathology, which kind of links into what Anne-Marie just said.
Yeah, really good.
So yeah, so it's purposeful.
Lovely. I'm fearful now that I've asked such a good group of people that you're going to steal all my wisdom here by answering all of the questions, giving all the answers. It's great. Anything else?
Well, to hopefully help them.
Yeah, how can you elaborate a bit? How do you think that goals are helpful?
Well, so that you know the things that they want to be able to do and the things that are really important to them. So, you know, why they're actually seeing you in the first place.
Lovely. Yeah. So some of the things we just jotted down, I guess, providing structure and focus to our treatment. So I guess goals give us, physios by nature are very task orientated, I think, and we like to have structure and focus. So it gives that plan, if you like, informing our treatment. Someone mentioned before establishing realistic expectations with the patient. So that realistic is really important. We'll talk a little bit more about SMART goals as we go through this, but knowing what the patient expects from that consultation is going to be really crucial. To create an agreement with the patient. So again, it's getting that sort of buy-in, and we're increasing the patient empowerment or the motivation, in some ways enhancing self-efficacy, which is again really important. We'll talk more about that, the importance of self-efficacy as we move through, particularly into the high-risk patients. Someone already mentioned facilitate problem solving. And again, really important for us is demonstrating positive outcomes. Those are possibly some of the good reasons why we might do that. So I'm nervous about this, given our experience with the breakout room so far, but we think that the best way to kind of get a sense of goal setting is through role play. So the plan here is to give these breakout rooms one more go. Laura's assured me we can now do it, and I want just to take sort of 10 minutes in pairs or threes or wherever you end up, role play where one person is the physio, and as a physio you're asking the other person for their goal. And I really want you to think about this process of of you developing the goal for them. So the physiotherapist is telling them how can they go about achieving the goal, how can they go about progressing with it, and so on. So we're really taking the approach to us as clinicians managing this goal that the patient sets, and just for a couple of minutes, and then switch over, and then we'll come back in 10 minutes if that's okay. So we'll try it if everyone's willing to. It's 10:40, so if we go for 10:50 to come back, assuming that it works, I don't know what we're going to do if it doesn't. So can we try those links again?
I have to say I've tried one of them and it worked for me. So I basically barged into somebody's break room and it was working fine. And I was the first one, so that didn't seem to be a problem.
Great.
Do you know if we have to close down this meeting first?
You have to leave. You have to leave this meeting. Yeah.
I think for me, because I'm having difficulty on my browser, that it's not updated on Teams, so that's why I'm not being able to.
Yeah, that may be the problem. Yes.
I'll try again.
The alternative, what you can do, is going to take you literally 2-3 minutes, is just download the client. And then the client will let you a bit more.
Right. Okay. I'll see if I can try and leave this one and come back.
Yeah, I can see, Adrian, there's lots of people in the list that say on hold. So I'm wondering if they're having problems because they're not leaving the meeting.
Yeah, they need to basically completely leave. That's what I was. So whoever's still on here, please, if you want to join the breakout room, please leave completely. Just basically complete that as if you've just finished and going away, and then join that breakout room. I can see you now, Laura.
Yeah, it looks like people have. It looks like it's working.
Yeah.
Oh, good. Someone's just said,
I can see.
Can you remind us what the role play scenario is? Yes, I'll just paste it in. Hang on a second. Copy that. Let's see.
Yeah, I guess if you just click on the link without leaving that, it'll just puts you on hold. That might not work.
Same.
Anybody left in this room?
No, we're still here.
It seems to have worked that time, I think.
I'm still here. So I'll put my camera on. It still won't let me in. I'm waiting to be admitted, and the other person is also waiting to be admitted, who I'm with. So.
Have you left this completely?
Yeah. I've been out of this and tried to go in the other one.
I have no idea how that works.
Do you want to do role play with me then, Joe? I'm very happy.
What you wish for, though.
I'm very happy.
All right, then.
Is there anybody else left in who needs to do role play?
Oh, actually, to be honest, I think. Oh, hang on a minute. My Teams is going on my phone.
Oh.
So you actually are still joined there because you logged into on your phone client. That. That might be the problem.
People are coming back.
I haven't done anything on my phone with Teams.
Rob, did it work or not?
It didn't for me, but it has for George. He's sat opposite me. So he's
Rob,
in
you
the
just
room having a
role play with George.
Yeah.
Yeah, I'll join in with them.
All right. Thank you. Thanks for your understanding. Nicholas, did it work for you?
No, it didn't work for me.
Okay. Should we do some role play here then? Well, everybody, so I'm happy to do role play here. So what have we got to do? One person plays a therapist, and the therapist asks for their goal. Right. Okay. So do you want to be therapist and I'll be patient?
Is that speaking to me? Is it? Okay.
Yeah.
Okay. Yeah, go on then.
So yeah. So
I'm the therapist, am I?
Yeah.
Okay.
Okay. So I've had this back pain for 3 weeks. Can't go to work, can't sit. I want to scan. The doctor's told me the only way to sort this out is to get a scan.
So
when can I have the scan, Rob? Nick?
What do you think a scan is going to be able to show you? What have you been told before? What do you think is a scanning really going to really help you with?
Well, the doctor says if you do me a scan and it shows I've got a disc bulge, then I can have an operation and it'll cure me.
And do you think an operation, is that something you're really searching for at the moment? Is that something you'd really like to go down that line?
Yeah, I can't put up with this pain any longer. It's horrible. I can't go to work.
What's the pain stopping you from doing at the moment?
Going to work. I can't sit, can't sleep. Feel absolutely shattered because I'm not getting any sleep. I'm nagging with my kids, nagging with my husband. I'm a nightmare.
Okay, don't forget to throw in a goal pretty quickly. Give him your goal so that you can.
Yeah, I want to be pain free. I want to be pain free by a week on Friday. Your worst nightmare.
Yeah. And what is it you feel that you would be able to do? Or what does your work involve? What do you actually do for work?
I do a lot of sitting.
Yeah.
A lot of computer work.
And have you got some ways that you're able to try and change that at the moment? Are you able to get up and move around a little bit more often?
It's just so painful, But I think the scan would sort it.
Are we still doing goal setting, or are we doing a whole role play of more?
Yeah, goal setting, Nicholas. You're right there. Try and develop her goal of pain free. How is she going to get there?
So are there any ways that you think you'd be able to do some of your job without, with still being in some of your pain? So are you able to perhaps sort of sit for maybe half an hour before you actually are able to change your position? Is that something you'd be able to do?
Yeah, I think so. Yes, I've not thought about that. Yeah, I could break it. Do you mean sort of break it up a little bit, do a little bit, and then?
So for some people, they tell me that they can manage their pain, or they can get through their working day by splitting it up into more manageable chunks. So how long do you think you'd be able to sit for at the moment before you'd have to get up? And even though I understand you're in pain, how long do you think you'd be able to sit for before you could actually change position?
Well, I could as well. What do you think if I try to kind of raise up my workstation? So, rather than having to sit, maybe try and stand a bit.
Yeah, that's a great idea if you've got the facility to be able to do that. And a lot of people do find that changing their position to standing can be a really good way of doing things.
Okay.
Do you find that standing is something you can try and do for a few minutes?
Sorry, I missed that bit. Did you say?
Do you feel that standing is something you can try and do for a few minutes to carry on working?
Yeah, I could try that. Yeah.
And then do you think you may be able to try and sit for a few minutes as well?
You mean like just break it up a little bit and do a bit of sitting, then do a bit of standing, do a bit of sitting?
Yeah, possibly. How does that sound to you?
Yeah, I could try that. I could try breaking it up a little bit, see if I can raise my workstation up a bit. Yeah, okay, I can try that.
Yeah, and so do you think that how long of work do you have to be in one position for? Or how long is your working day?
It can sort of be up to sort of 12 hours.
Wow. And do you have any negotiations with your employers to be able to change that work hours, or to be able to spread it out across a few different days?
No, but now you kind of just made me think about, taking those regular breaks, maybe just being a bit more mindful of that and just trying to build that in, rather than kind of thinking I've got to be at work. I think because you work at home, you feel like you're guilty if you're away from your desk. So
yeah.
Kind of, maybe I've just got to break that mindset a bit of, it is okay to have a lunch break and perhaps stand and have a walk.
Absolutely, yeah. And have you found that walking actually helps you at all?
Yeah. I think partly because, if it's a nice day, you're out in the fresh air, and it helps the pain a little bit, but it helps you kind of your headspace a bit as well, doesn't it?
Yeah, definitely. And other sort of things. Would you be okay if I tell you of a few other tips that other patients have told me that have been helpful for you?
Yeah, that'd be lovely. That'd be great.
Some people have been talking about trying to do some of their meetings on if they've got access to their phone or their tablet, and they do some of their meetings while standing up and walking around, rather than always being sat at a desk. That they've changed just the way that they've been working, of holding some of their meetings outdoors whilst walking along out in the park. Other people have been able just to change, so having a certain number of times that they're sat down, a certain number of minutes that they may be standing up, and just mixing the day up a little bit.
Okay.
So that's something you might want to try out.
Lovely. Yeah, I'll give that a go. Thank you. That's really helpful.
And do you think perhaps over a period of the next sort of week, do you think you'd be able to make a some people find it useful to make a bit of a chart of how useful that's been to them as to how many times they can change position during each day and see what works for them. It may not be immediately that it helps them, but it may actually be that they can change that and see, does that actually help you? And we can come back next time to see how you've managed to see put some of those practices into place really.
Yeah, and I might set an alarm as well, because I think sometimes when you get into doing things, you get so focused that time flies by, doesn't it? And you forget, 2 hours is gone. You think, oh my goodness, so perhaps setting an alarm.
Yeah, and another tip that patients have said, if you are going to set an alarm, is make sure it's in a position that you can't just turn it off right next to your computer. You actually have to get up to try and change the position.
I like that. Yeah, because otherwise sometimes you can be so into something you kind of just carry on and just turn it off. Yeah,
exactly. Yeah. Good. So it sounds like you've got a few things you can try and work on, and before we talk next time, is to try and work on some of those changes of positions. Do you think that's manageable for you?
Yeah, I'll give that a try. I'll try the workstation, try standing more, breaking the day up, using an alarm, utilising that walking, and kind of using the tech, using the phone so it can be up and about a little bit more frequent.
Yeah, definitely. Yeah. And are you a sort of tech sort of person? Are you somebody who uses technology to be able to try and help yourself with these things?
No, I wouldn't describe myself as a techie person, but I'm willing to give it a go. I'll try my best to kind of download stuff on the phone. So yeah.
Guys, that was awesome. I think people are starting to come back. So we've probably all got the end of that lovely role play between Nicholas and Kevin. Should we? I don't know how accurate my numbers are. It says 47. Still a few people that say on hold. Just give it a minute.
I think there's a few people just coming back in again now.
Right. Yeah, that's good. So I'm assuming most people are back. Did that work? First of all, is that a more successful breakout experience? Yeah.
Breakout worked better.
Lovely. Thanks for that, Laura. Great work. We get there eventually. So for some people that didn't get away, they were just doing a bit of role play in this main room, but be interesting just to hear how you felt that went, and just give us a bit of a discussion around what that was like. So just bearing in mind that exercise there in the role play, this sort of instruction was really about the physiotherapist asking for the goal and then them being really the driver in developing that for them. So does anyone want to pitch in with how it went and how it felt?
I think for us, Debbie did a really good job of sort of asking about the barriers first. So, and that kind of led the conversation then. So we spent a bit of time exploring the barriers to reaching the goal and how that then sort of developed how the goal might pan out.
Okay, so the barriers you were asked, the physiotherapist was asking the patient for barriers, because that's quite a nice approach. Okay, and anyone else there see some hands up? Is it Chris?
Oh yeah, hi. Yeah, it was interesting. I think physios know which buttons to push when it comes to saying things that are going to make it difficult for you to get information or to move forward with the interview. But again, it's quite interesting because you can kind of the physios take on the role play of somebody who's got a very strong biomedical understanding of their problem, and it's the time and space and the communication strategies, as you were talking about earlier, to try and introduce causation, other types of problems that the types of factors that might be impinging on their pain into the conversation. And that for me is always the really tricky bit, is transitioning between a biomedical discussion and a multi-causational discussion. That's where the strategies need to sort of, for me, that's what I'll be interested in trying to get better at doing, because I think that's a really hard thing to do.
Fantastic. Yeah.
Particularly in a short space of time. If you've got 20 or 30 minutes in an FCP consultation, trying to get some sense of what's factoring into their pain apart from their crusty knee, which is what Tom presented me with, it is a challenge, definitely.
Yeah, absolutely. Well, I mean, and it is, and I think that the variables are there, aren't they? It changes with each person that sits in front of us, so it's not a one-size-fits-all approach, but hopefully we can get a bit more practice of that as we go through these next few days, next couple of days. George, thanks for that, Chris. I think George has his hand up.
Yeah, so Laura was with me, and Laura did a really good job of kind of understanding what that goal actually involved, so that really kind of that there was that shared understanding going forwards of what we were looking to try and achieve together. And then I think off that, then really trying to that kind of negotiation and communication around, what my concerns might be. So those barriers that Delith was kind of reflecting on, kind of what opportunities, we might have, and about trying to then get to a point where there was kind of confidence going forwards that we were agreeing a plan that seemed deliverable. So yeah, I think it's what we're doing day to day, and it can be pitched at kind of high functional levels or basic functional levels. But yeah, it was kind of useful to have that conversation.
That's great. Thanks, George. Yeah, I mean, I guess it is tricky, I suppose, again, just to reiterate with this particular one, we were thinking, really trying to, I guess, do the wrong thing in a sense, and that can be quite, not necessarily the wrong thing, but the thing that might be least helpful. And that can be quite tricky, especially if you've got those skills kind of embedded in your communication already. So yeah, well done, George and Laura. I'll just see if I can, does anyone else want to chuck something in there? If I can share the screen again. This goes back to the start. So we've done a bit of practice. So here's the thing really that I wanted to talk about next. So in your role plays there, it'd be interesting just to hear what the common theme was that people brought to the consultation. So if I had to describe my experience of what someone consulting with pain would want, it's often to have less pain. And if someone is consulting with pain, then it follows that any notion of goal setting will often default to them reducing their pain. And that's generally because if we think about it from a psychological impact, our minds are flooded with thoughts that highlight the impact of the pain on their day-to-day lives. And it really reinforces this idea that they're unable to achieve any goals of returning to normal life without first reducing the pain. So for me, I often hear people say, well, if I can just get rid of this pain, then I will be able to achieve this. Or when I can control my pain, I can do this. Or as things get better pain-wise, I will be able to go back to normal life. And the correlation here is often between the idea of being pain-free and carrying on with normal life. Does that reflect, did anyone either hear that in their role play with each other, or does that reflect what we hear generally in practice?
That's exactly what we did, Stephen, because that's the struggle I always find is the patients that they can't come up with any sort of functional goal other than, yeah, but I could do that if I didn't have my pain. It's all about the pain, and I find that difficult sometimes to get them to sort of move on and stop sort of thinking about it that way. But I often try and turn it around and make them sort of say, well, if pain was that easy just to get rid of, it would have been done by now. Somebody would have done that by now. You've had it for X amount of years, and sort of make them realize, actually, you're right. The pain isn't the easy bit to tackle.
Yeah, fantastic. Thanks, Samantha. That's great. Anything to add there, anyone? Okay. So
I was going to say that it's sometimes just trying to change change their terminology and shown to change the word of pain, or change their focus from pain to sensitivity. That if we can try and encourage them to think that their pain system, their nervous system, has become more sensitive, and that's the sensitivity is driving their pain, that we can try and use that changing their function and using an increase in their function can reduce their sensitivity, and then the idea that hopefully with the reduction in sensitivity that will then have an impact on their pain. So just trying to change their terminology a little bit.
Yeah, absolutely. And it all kind of overlaps, doesn't it, and links together. You're talking really about, in a sense, pain education, their understanding, and then that will link back to the communication that we've talked about this morning, and how we get that information across. And then, of course, that will impact on the ability to set goals in the longer term.
I think, as Sam said, I think it's just to say that you can still achieve your goals despite the pain, and the pain will perhaps be with you for quite some time, you know, maybe forever, but you can still live well, is the important message.
It really is, yeah, absolutely. And it's how do we get that across? How do we go about helping someone to understand that point of view, and I guess live it in a sense, because again that comes back to the conversation we've had already this morning about the difference between what we understand, what we as clinicians or pain experts know is possible, and the individual's current situation and where they are in that journey, in that process, and whether they can get on board, and whether it's the right time for them to do that. Absolutely. It's really tricky, isn't it, when the pain-free seems to be the focus, and it's tricky because we often know that it can be unrealistic, but often we also have this empathetic side that says, yeah, look, it makes sense, right? You know, of course, it follows all human logic that we would want to get rid of this pain. So just here thinking about what we do when the patient has this pain-free goal, and how do we evaluate how workable it's likely to be. So, you know, we talked about this as a problem, but how do we feel, what are your views or ideas about managing this expectation of being pain-free? Are there specific barriers that might show up that might make it unworkable? You know, what kind of things would lead you to, you know, what are the barriers to this not being a goal that we think is useful in practice? What about returning to activities of daily life? You know, so if they're convinced or concerned, should say, about making things worse or doing more damage, you know, this concept of hurt and harm, how would we manage that kind of thing? How do we work out whether this is an achievable or, you know, a workable goal for them?
I tend to get them to reflect back on everything they've tried so far today and what effect has that had on their symptoms. And then they've tried this drug and that strategy and this cream and that, you know, whatever, and this, and you know, what effect has had any of that had on your symptoms. So hopefully by reflecting on what they've already tried and the fact that it hasn't helped them, hopefully allows them to then come to the realization that actually, you know, is there going to be a golden bullet that is going to take the pain away, or, you know, are we going to have to accept it to a certain extent?
That's really good. We call, when we deliver that session in our pain management program, we call it creative hopelessness. I don't know if that's a phrase that's familiar to people, but it is exactly that. You know, it's really sort of thinking about just bringing awareness of the patient to all of the things that they've tried in the past, and you're trying to do that in a non-judgmental way, just sort of bringing it up so that it's on the table there, and hopefully bringing their attention to the fact that, yeah, this is a problem that hasn't gone away regardless of how hard I've tried, and all these different things. And again, we're sort of bridging over, aren't we, low, medium and high risk groups here, and we'll talk about the implications of this more in each of those groups, but it's definitely something to consider. Is it Rob? Rob, have your hand up.
Yeah, I was just going to say there's some really interesting stuff there about causation, isn't there? You know, if pain-free is a goal, it's what you understand that as being, and whether pain is something from a causation perspective that can just disappear or be switched on or switched off, and whether the conversation about causation of pain then actually leads to the idea that alternative goals will lead in that direction, and that perhaps that as an initial direction is not. Whilst it might be a longer term goal, it's not necessarily the initial step in that causation ladder, and understanding the complexity and the number of different factors that could be attributing to that in the first place. So I think that can be a useful thing to take that step back and just, you know, talk about why they're currently in pain and what all those different variables might be. Yeah,
absolutely. And that's a great point. And I think as well that will vary across the different risk groups, Rob, won't it? You know, and what those barriers, those causes might be. That's really, really interesting. Have you? I mean, I'm sure. Sorry, go on, Chris. I think to your hand there.
Yeah, that's exactly what I was saying, and then but the strategy for actually communicating. So that transition. I'd be interested to see what people think about the transition between, you know, where they've had that nexus between, you know, GPs and consultants and the very biomedicalized view that they've had of their problem in terms of causation, and transitioning that to a multi-causational model that Rob was alluding to just there. That for me is the crux of the communication paradox, the difficulty, so to speak, of what we actually have to try and achieve in a few sessions, is moving a patient potentially from that idea of a single causation to multiple causational relationships, and how those relationships can even be sort of codependent and what they're called mutual manifestation partnerships, where one thing affects another in the environment they're in. And it's a conversation I've been trying to have with patients more and more, but there's no roadmap. It's a really you know, we've already alluded to the fact it's bespoke, right? But it's a difficult conversation to have. So it'd be interesting to see what people think about that.
Yeah, absolutely. Jump in if anyone's got any thoughts on that. I suppose the difficulty for me really in thinking about the barrier here of time, which seems to be something that keeps coming up and is understandable. It's about how much we realistically can achieve in that session. And just to go back to that kind of point that I came in with earlier, just about keeping one eye on the goal for you as a therapist working with people in pain, and you know, what is the purpose behind this approach? Can we let go of the idea of trying to get all of these things done and spend that consultation focusing on something that might be beneficial, even if we don't get all of the things that, you know, are on our list of things to ask. We do some teaching with medical students, third-year medical students at Keele, and that always comes up. You know, it's this barrier between achieving what their consultant has told them to achieve in that time frame, and having an understanding of why we're even doing this, and being able to sort of stick to that as an individual and say, you know, make those decisions on the fly, I guess. I hope that makes sense. Some hands are Rob and Robert Goldsmith, I think.
Yeah, I think we just need to start from, I think, from their understanding of why they're in pain. We need to take a step back rather than immediately imposing our understanding of the multifaceted nature of pain and what causes it. Before we can get to that, I think we need to start from, why do you think you're in pain? What's your underlying model for understanding why you're feeling like this? And that kind of then we need to move that model on before we can start to introduce a more complex model that might be more helpful. And I think for some people, there's nudging someone into acceptance is often a journey rather than a one-off interaction, and just leaving that consultation with, this is what I can offer you. This is what I think would be helpful. This is what's on offer. You don't have to take that up today, but if you want to go on a bit more of a diagnostic journey in your mind, in your biomedical view, we're still here, you know, and right. It may not be the right time right now, but we'll wait. We'll still be here.
Yeah, for sure. And as a service, that's we spend a lot of our time doing that. You know, we assess lots of people who just for one reason or another aren't in the place where this message can really be heard or actioned. And again, just to go back to that point of just understanding the purpose of your role in this and saying, you know, this is the science, this is the facts, this is what I believe, and this is what I think will be helpful for you, and just kind of I suppose just sticking with what you think and sort of just giving them that option not to be involved at this time, which is great. Rob as well.
Yeah, sorry, Stephen. I just wanted to agree with what you're saying earlier about you know, the way that we do things, and the bottom line is that this is a paradigm shift in terms of the way that we're dealing with things. It's not about trying to add psychology or sociology into a biomedical model. It's about trying to adapt to a wider model. And I think there is that point, as you said earlier, where we have to start to say, well, what from the past remains useful, and take some brave steps to do things in a different way, and that will be uncomfortable. But I just want to reassure everybody on the call that, you know, we're ready to take those risks, you know, because we know that those risks, the data all shows that they're worth taking. Exactly. And we need to support each other with the discomfort that comes with that. So yeah, it's just an agreement, really.
Yeah, great point. Thanks, Thomas.
Yeah, just following on from what Rob said there, really, I think when you talk about shifting in communicating, we can be very good at sort of clinically assessing and criteria for the biomedical world, and you can get yes and no's and things, and then even the psychological assessment, you can get outcome measures that really grade it and they mark it and they can define things very clearly, which is easy. Second, you go into social, it's a lot more open and it's a lot more sort of widespread and interpretive, and that can be really challenging as well, where can be a lot of comfort to saying there's a score there, isn't there? And so that's one of the big challenges, that it is uncomfortable getting a purely subjective outcome.
Yeah, and I think this it's an important thing to consider, isn't it? That we again as physios historically have been obsessed with outcomes that show something. What we're doing in our service at the moment, and very very conscious of, is we're trying to evaluate what it is we're delivering, and whether the outcome measures that we're using really get to the crux of what we hope we're achieving. And there will be times where you think, this is really just answering a question, but it's not digging into the why here. A really useful point. Outcome measures is a massive conversation, isn't it? Okay, so if we spend a bit of time talking about this, hopefully some of you may be familiar with this, but we call it values-based goal setting. So we really feel that, if possible, goals should be based on something that feels important to you. And hopefully from the role play that we did before, when we do the next bit, that this will start to come through. But if we're behaving in a way that's in keeping with the things that feel most important to us, then effectively that is what we would call living by your values. And for me, it's about distinguishing the difference between values and goals here. So if the goal is the end game, it's the destination, it's where we want to be, it can be really helpful to think about the values in that as the compass that's guiding the direction of travel, or sometimes the value can be that direction, that journey, if you like. Because we know it's easier, right, to get somewhere when you're going in the right direction. You feel that you're on the path to what it is that matters. And I guess by following this approach, you feel that your life is going in a direction you want it to do, despite all of the other challenges that might show up, which obviously for the context of this couple of days is pain. So it's just that message really from us that says it's values first and then goals. This is a really important message, and all of those other barriers start to come into play, that we've talked about in terms of, well, how do we get the time to have these conversations and so on and so forth. But having that in the back of your mind, that a goal really only becomes most effective when it's linked to values. but for many people, it's really tough to work out what your values are and whether you're in pain or not. If I was to ask every one of you, tell me your values, it's a really difficult introspective question. And we often default to these kind of standard things that we've been conditioned, to think that we want to be. And again, that's a different conversation. But if someone's living with pain, this understanding your values can be even harder. And values can simply become the what for them. It's that thing that they just do. It's the thing that's expected of them, or the thing that they've always done up until now. And really what we're saying here is that values should be always about the why. If you know your why, then your what has more impact, because you generally will be walking in the direction of your purpose. And we'll go into this in more detail when we're talking about high-risk patients, because I think that's probably where this becomes more relevant. But I'm just hopeful that this short video will, I'm conscious of time, but it's only a couple of minutes, and I hope it demonstrates the point. So let me know that you can see this.
I can't.
You can't hear or can't see?
Can't see.
Okay.
I'll watch one of the others. It's okay.
Okay.
I can see it okay.
I can't hear or see.
I can hear it, but it's coming through a different audio to my headphones.
Yeah.
Okay. I'm just going to try stopping the presentation, starting it again, just to see if that helps. Sometimes just giving it a little bit of a kick.
No, he started it.
It might have been me. I just pressed the play button. I don't know.
Okay, so hang fire. Well, that wasn't so helpful. I think I managed to kick myself out of my own meeting. Let's try again. All right, include the sound. Maybe this is going to work. So goal setting, and let's try. Is it working now, guys? Yeah, for some.
Yeah.
It's not for me. I just.
Okay. I'm hopeful that you guys were able to see that. I absolutely love that video. I think it's brilliant and hopefully demonstrates what we're talking about. So it's just this subtle difference, isn't it, between being able to do something or doing something because we can, or is expected of us, or it's just part of our job, or it's the thing that we do. And then the difference in that thing when we start to look at why we do it, what's the importance, what's the feeling behind it, what's the meaning, and hopefully we can relate that to goal setting in the sense that if we think about what I was asking you to do earlier, so someone comes to a consultation and the physio sets the goal for them effectively and then tells them how to manage it and how to get there. We're never really tapping into the why. Why is this thing important? What does it mean to you? And how do we get some of this? We're much more likely to achieve that if we can get it. So hopefully that makes that point. Michael Jr.'s face, that was one of the funniest things for me. It's just hilarious. Okay. So someone mentioned different parts of this SMART goals process before. So I'm assuming that most people will be familiar with SMART goals, but just thinking about when we identify the why and thinking about how do we put that into practice, how do we make it SMART. So being specific is sort of increasing the specificity of the goal, helps to sharpen the focus on what you want to achieve, putting some kind of measure on it so that you can plan the various stages as you would go along. Knowing how much of something you intend to do helps you work out if it's achievable. So thinking about, are you likely to be able to do it? Is it something that's realistic and within your grasp? And then for obvious reasons, and as we've been shown there, it helps if the goal feels rewarding. So the R can often be realistic, but we like to think of it as rewarding as well. And then thinking about specific timeframes that help you keep things on track. So in some cases, and particularly in our low risk, in some of our medium risk groups, this goal of being pain-free that we talked about at the start may actually be workable. But often it isn't. Often it doesn't tick any of these SMART boxes, and it certainly doesn't have, in that presentation, it doesn't have the why, and so that's really what we want to get to. So just to go back to that question, how do we manage this unworkable goal that's compassionate with our patients? And again, not for the first time, we're linking this directly back to our communication skills, because that's certainly going to make all the difference in terms of, whether we can normalize this, whether we can validate, whether we can explore, whether we can clarify, whether we can use all of those Socratic questioning skills in order to manage their expectation that really isn't going or isn't likely to be workable. Think about, as a question, how do we help people to understand their why? How do we help them to identify their why? Can we introduce values into the consultation by asking questions like, what would having less pain enable you to do? Really digging into what's behind the less pain thing. What are the things that are important to them that go in behind there? Starting to introduce the idea by asking questions of, do we need less pain to begin to take steps towards this goal that we've identified? If it's important, if you understand the why, if you know that it adds value, is it something that you might be willing to do with pain? And again, not saying that a patient can, or a person can never be pain-free, but just trying to really reinforce the idea that it doesn't need to be a prerequisite to reaching the goals that they're setting. We're really trying to break the correlation between being pain-free and leading a normal life or their best quality life. And helping patients to understand and explore the idea that they don't need to be pain-free to get back to normal activities or to return to work. So just the last thing then on this bit is just a couple of ideas from me in terms of what questions, and we'll add this to the chat or we'll make this available to you, but questions that might help you explore values within the goals for a patient. So things like, what is it that you really want? What do you want your life to stand for? What sort of person do you want to be? What sort of relationships do you want to build in life? How do you want to act or behave in the world towards others or towards yourself? And what do you want to do with your life? These are really difficult questions. And again, I understand that it may be difficult to do all of these in your consultations, and we have to pick and choose. But just some examples there of what might be useful in terms of that. Before we move on, what are our thoughts on all of that we talked about? Going back to the values stuff, the values-based goal setting, understanding your why, and then making that smart and then delivering it in a compassionate way.
I think that's really good. I like a lot of those sort of things. I've just got one question, perhaps to yourself or to other people, is that do other people sort of find that has a patient potentially come to us to have all those questions asked to them? So I think it comes back to the patient's understanding of what they're actually coming into. For them, they're coming into a point of they want to have their back pain addressed. They don't necessarily make all the links between what we've been talking about with their reason for why, with how that help them with their back pain, that they feel this has become too much of a psychology session, counselling session, rather than actually a physiotherapy session. So I'm just wondering if other people come across those challenges as well.
Yeah, I mean, I'll let other people jump in first, probably, if that's all right. Rob?
So I guess from my perspective, Stephen, you're talking very much from that sort of pain perspective, aren't you?
Yeah.
Whereas we're working across the whole spectrum. So yeah, I guess that as with everything that we're talking about today, I guess we're talking about a selection of tools, aren't we, and a selection of techniques and a selections of views of the world, and it's picking the right ones for the right person at the right time. Which I would say with that. So I agree, Nick. We're not going to be doing this with everybody coming through the door, but it's having that tool in your armory for that person that needs that or that's going to respond to that. I would say that's how I tend to think about it. It's about filling your toolbox up, isn't it?
It is. You both make some good points there. I think what I would suggest is, or my take on that, is that we're, as you said, we're talking generally across this low, medium, and high risk stratification, aren't we? And you're right, we won't be going into, either because we don't have the time or because it's not required, we probably won't be going into all of this with all of our patients, and certainly unlikely to in the low risk. It's just a really useful kind of way to bring our attention to a different way of us thinking about goal setting as well. It's something that I feel that when it becomes part of your own values, when you as a physiotherapist are setting goals that come from this place, it really changes the way that we consult in other groups as well. It kind of just adds a different dynamic to it. So it's again, without reusing it, it's knowing your why in your role. Even if you're not using that particular skill for every patient, I just firmly believe that it changes the way that you consult even in the low risk category, by having an understanding of this and just being aware all of the time that this compassionate approach can be helpful more often than not. I mean, who doesn't want to experience that in a consultation? And I hope that makes sense. Does anyone else have anything else to add? We've got Joe.
Yeah, I mean, I just think that a lot of these conversations are really challenging and really hard work, and often there are no answers, there are no solutions, you don't come to firm conclusions. That doesn't mean that the conversations shouldn't take place, but it's tough.
Mm-hmm.
You're not coming up with answers to all of this, are you, as a physio, which is challenging.
Yeah, agreed. I think just Rob's got his hand up, and then we'll try and wrap up, just thinking of time.
Sorry, that's a legacy hand.
Oh, okay. Let's
Try
kind
and
of go
get
through.
it
Sorry,
again now.
mine's a
Go through
legacy
a
hand as well. My PC is really slow. Sorry.
Yeah, no worries.
I've lost my hand button. There we go.
All right. So, I mean, we had planned here to repeat that role-playing action there, and just sort of, really the aim here is to show the advantage of patient-generated values-based SMART goals against the stuff that we did earlier, which is the therapist kind of generating the goal and driving it, and just reinforcing that the patient-generated goals are more meaningful, more likely to be adhered to, and just more valuable generally. I'm pretty confident that from what I've heard from you guys already, that we can probably skip over that and keep on top of this little bit of extra time that we've managed to create, if that's okay. So any further discussion, any other points that anyone wants to bring into goal setting? And again, just to finish and say, we will apply goal setting and communication to the individual risk groups as it becomes more appropriate to do. But this really was just an overview of the importance and the principles of goal setting in general. Okay, cool. Well, in that case, we'll leave it there. I'm just trying to look for the timetable. I think, is there a break now, Kay, or do we move straight on to the...
So, I mean, if you want to take a break, that's fine. I think the next session is applying the principles to the low risk group. So we've got until 12:30 to do that. So you've got 45 minutes. So if you want to take a break for a 10-minute break, you're on time then. So that would be fine if people want to stretch and come back in 10 minutes. Would that be okay?
That's all right.
Yeah, okay, lovely. So see you at 11:45. Thanks, Steve. Great session.
Yes.
Denise, are you there? How's Neve? You're muted.
Hi, Joe. Yeah, she's good, thanks. Are we talking just you and me, or are we talking to everyone?
I think everyone has buggered off.
No, we can all hear you, just so you know.
Yeah, we can hear you. I haven't logged off yet.
So I tell you what, that bloody lot in physio.
I know. Well, I mean, and what about the ones up in Kiel? I mean, goodness me.
Yeah.
No wonder property prices are low up in Kiel. That's all I'm saying.
Hey,
She's
Kay,
lovely, that Kay, though. I mean, if Kay was ever my patient, she'd be a dream, of course.
Brilliant.
Thank you, Joe.
Kay, I was watching your video. I was watching your video yesterday of your on the online training of you doing the low, medium, and high consultations.
I'm so sorry. I am so sorry.
No, really, really helpful.
Oh, honestly, it was hilarious, really, because I mean, there's always a story, isn't there? You kind of figure that with us guys. There's always a story, but we sort of had to do that fairly last minute. Adrian and Laura will kind of fill you in, but yeah. So Paul was great, the guy who was playing the patient. But honestly, when we got to the high risk, have you got to the high risk, Roger?
I can't wait. No, this viewing is still ahead of me because I was on annual leave.
Honest, those are the patients that are like, well, I need a scan. I've had it for 2 years. That and it's like there must be an answer. So
I know, and he played it absolutely beautifully because I was starting to get
yeah, you were like, oh,
I was starting to get a bit of not a reaction, but you just really kind of go, gosh, you're really challenging me, and that's good. But trying to do it in front of the camera as well, it was it was really interesting. So I reflected a lot on my communication skills doing that. But I'm glad it was helpful because it was
very, very calm. Very, paced.
Yeah.
Whereas in real clinical practice, you feel you've got time pressures.
And honestly, with the Stephen and Katie will probably say the same, but I always find that the kind of the challenging patients for us are often, just let them talk more than I talk, because I think the more, I very often, just the complaints we get in our service, we don't get very many, but when we do, it's generally around communication. And patients say, I haven't been heard, I haven't been able to tell my story, nobody listened to me. And yet when I look at the letter, everything's there. So clearly the experiences of what they experience is different to what us as clinicians, we've got all the kind of red flags and we've got it all written down perfectly, but the patient actually feels that that's been a great conversation. And the two sometimes don't marry, do they? So just letting people talk, I find, is really helpful.
And I think the majority of patients are on a journey, and they might not want to hear it from you, and it might be completely against the grain. However, if then the next person they meet is saying similar sort of things, they might actually, and that their reflection on the experience with you is like, that was bloody rubbish, they didn't give me any answers. But actually when they reflect back on it, you think perhaps you've just moved them in the direction that they need to be going, even though they don't necessarily agree with you at the time.
I mean, I kind of think,
This is how do I know why I'm here? Because when you know your why,
somebody's playing the video.
Yeah, brilliant, absolutely brilliant.
Like for instance, people know how to do comedy, but that's what I do.
Right.
Why is to inspire people on purpose. So I can do comedy. I can write books.
We can't talk anymore.
Because
Nick,
all
I think you're playing your video too loud.
Somebody's
Can you
not
mute
on
yourself,
mute.
Nick?
I don't think it's Nick. Nick, which
Barton?
Nick is it?
ND. Nick Barton is highlighted as being the loudest on this clip.
See? How did you know that?
The circle lies. Now he's gone.
Oh, there we go.
The circle lit up.
Well, yeah.
Ah.
Sorry, Kay.
Not that I'm an expert.
That's all right. It's all right. Yeah, you sometimes do forget, don't you, what it's like to kind of arrive, what people are coming to.
Yeah.
We're so busy, and yet people arrive anxious, really concerned.
Yeah.
Bring a lot of emotion, don't they? With
and you come into that blood. I had a consultation a few weeks ago where I could see so I do first contact physio, so we use the patient's GP notes, and in the GP notes it's patient, so long-standing history of multiple joint aches and pains, very biomedical, ex-nurse or whatever, had lots of tests, all negative, and so the GP's plan in his notes had written, patient not happy with management so far, but we're going to carry on with anti-inflammatories and refer for physio. So then I could see that the patient wasn't happy, but I'm going to be positive and I'm going to give it my all. And so when I just said to him, so it's the physio here, so are you happy to speak to me? What are your main concerns at the moment? He was just like, well, this is absolutely ridiculous. I know. I said, yeah, I've got notes. I'm interested to find out the difficulties that you have. And at that point he said, right, I'm going back to the GP, and hung up on me. It was like, oh no. But I guess he was coming from a position where he's still really anxious about his diagnosis and what's going on, and obviously wasn't happy. So I tried not to take it too personally, but it is really tricky to deal with people like that, isn't it?
Yeah, it's hard. It's hard because most of us are facilitator types in physio, the majority of us, and so one of our kind of our sort of weak spots is that we sometimes have a bit of a thin skin, don't we? And it is really easy to kind of be wounded by that, but you're doing your very best for the patient all the time, aren't you? You're trying all the time to do your very, very best, and a lot of the time it is this communication. Steve and Katie are absolutely spot on, aren't they? Trying to get that right is right from the very off, right from the very first time that they contact your service, whether that's a letter or someone that's speaking to them. And we've had some what I've done in our service is I've had a secret shopper. So I've had someone sit in to listen to what goes on in the atmosphere around the clinics. So and this was as a reflection of one of my friends was in hospital, and when he was in hospital could hear everything that was being said at the nurse's station, could hear patient details, diagnoses, all sorts of things that he shouldn't have been able to hear. So I just kind of wondered, well, I wonder what happens when our patients sit and wait for us. What do they hear? This is really pre-COVID, and it was fascinating. Absolutely, the stuff that you shouldn't hear